Hello students, welcome to our lecture on Chapter 12. We're going to be covering a lot of psychological disorders today and some of their treatments. A lot of the treatment focused material is in Chapter 13, which we'll get to very soon, but today we'll focus on a lot of disorders themselves. We're not going to cover every single one of them in depth. As you know, in this class, a general psych class, we touch on a lot of topics, but we don't get a chance to dive deep into many of them. So let's get started with Chapter 12. And the first thing I want to point out to everyone in the class, as I check to make sure my recording is still going just fine, the first thing I want to point out to everyone is that you as a student watching this right now, most likely, unless it's been diagnosed and you're seeing a medical professional or a psychological professional for it, you probably do not have a psychological disorder. I know the first time I went through the only time I went through a general psych class as a student, we went over these chapters on disorders. And I kept seeing things like, oh, I have that symptom, I have that symptom, I have that symptom. I must have this disorder, and this disorder all together. Probably not, though. It's a common thing for us to pick out things that are similar to our lives, and that's good because it, as we've talked about in our memory chapters, that helps it make sense to us, helps us encode it better so that we remember that material. So that's not necessarily a bad thing. But I don't want you to get extra anxiety or stress because you fear you might have any of these disorders. If you pick up things that are similar to you, it doesn't mean that you have a disorder. If you are worried about it, definitely talk to a healthcare professional. Mention it to your doctor, see a psychologist, find a professional who can help you start those steps of getting diagnosed if you are really worried or you do need help. There's nothing wrong with that at all. I want to make sure you know, just because you might see a couple things that might sound similar to you, doesn't mean that you have a psychological disorder. Yeah, that's the main point there. So as you read it, you'll see maybe some similarities to your own life. It doesn't mean that these are disorders that you have. With that, any of these disorders can only be diagnosed by a professional. So I am not a clinical psychologist, I'm a developmental psychologist. My focus is in researching the development of prosociality, heroism, purpose in life, these kinds of things. So I am not a clinical psychologist. I have done ABA therapy in the past, and so we'll talk about that. We'll touch on that a little today, but mostly in Chapter 13. But I haven't done that in a professional setting for a while, so I'm not as up to date on the research in that. So I'm not, and even then, I was not trained to diagnose. I essentially had someone above me say, hey, this is this person's diagnosis, this is their treatment plan even, and you do the treatment plan. So that was my job, to run the treatment plan, not come up with the plans. So go see a professional if you're worried about it or have any concerns at all. There's really no bad reason to go and see a therapist. We'll talk about that at the end of the chapter. There's a lot of stigma around going to see a therapist or a psychiatrist. So you don't have to have that stigma. You don't have to be worried about getting that treatment. There's a lot of reasons to see a psychologist even outside of disorders as well. And so don't be afraid to do that. All right, so as we get into this, let's make a distinction between psychologist and psychiatrist. So we see psychiatrists here on this side, so kind of the teal, and psychologists here on this side, kind of the purple. So a psychologist, we'll start over here. I was going to try and not let my bias out, but psychologists, they're my favorites. So, which is why I went into psychology rather than psychiatry. But psychologists are a healthcare professional. They've completed a bachelor's degree and then either a master's or PhD, and they've trained in usually specific like classes of disorders, so maybe in anxiety disorders or marriage and family therapy, maybe ABA therapy. So they are either going to have a master's, a PhD, or a PsyD. A PsyD is a newer doctoral degree, so it's like on the same level as a PhD. Usually the PhD is a little different because the PhD has done a lot of research, like done their own research, like studies, not just reading research on through journals, which they've done that as well, but also running their own studies on these kinds of disorders and specific aspects of them. So that's PhD versus PsyD is very focused on the clinical application. So actually treating patients is what the PsyD has focused on in their training. The PhD will have also done that if they're a clinical psychologist or like a marriage and family therapist, but you can also have a master's degree and still do like counseling as well. So that's psychologist. You can think of that as the side that's like just talk therapy, but we'll talk about how they can also, in some places, prescribe medicines as well. On the other side, we have psychiatrists. So psychiatrists are medical professionals who have a degree in medicine. So a psychiatrist will have gone, if you have a family friend who is a doctor or anything like that, the psychiatrist and the podiatrist, your family doctor, the surgeon, they all went through the basic medical degree. So same kinds of courses, same basic material. And then they followed up with their residency in psychiatry. So there might be some courses, depending on the program, that they could take that are focused on psychiatry before that, but generally medical degrees across the US are pretty standardized. So you're going through the same kinds of courses, the same kinds of tests, no matter where you are at what school. You might have, you're obviously going to have different faculty, but they're pretty standardized. But what a psychiatrist will have done is, after that degree in medicine, get specialized training in treatment and medicines related to psychiatry specifically. So let's stay with the psychiatrist here, so still on this side. So a lot of what a psychiatrist does with that medical degree, a lot of their training will be on medicines. What are their side effects? What are the chemicals? How are those chemicals influencing the brain, the body, hormone levels, all those kinds of things. So that's what a psychiatrist will be really up to date on. And so what they will usually do is identify a particular disorder and then prescribe medicines for it. So in an actual sit down with a psychiatrist, what you would generally find would be you would have been maybe referred by a doctor, like your family doctor. You might have been referred to a psychiatrist by a psychologist even, or you might come in for some testing to the psychiatrist, and then you get a prescription. So let's say, for example, it's an antidepressant. So as we'll talk, antidepressants are used in a lot of different disorders, and we'll talk about a couple of those today and then more in chapter 13. But let's say you're prescribed an antidepressant for something. So you come in for your second meeting with a psychiatrist. It's a month or so later. You sit down, you have maybe 15 minutes with them, if that. They ask you how it's going, what side effects you might be experiencing, if it's been helping, additional things you think, additional symptoms that have popped up. So they'll essentially kind of see how the medicine is doing, have a short span of time with you, and then send you off on your way with the same prescription, an updated prescription, a new prescription, something like that. So that's not all they will do all the time, but that would be a pretty standard thing that you might see in a psychiatrist's office. Psychologists, on the other hand, most of what they're doing is supporting people by providing therapy. So we talked about how you could see this as like the talk therapy side of this. So they might be doing cognitive behavioral therapy, therapies on phobias specifically, marriage and family therapy. Especially in the past, a psychologist could not prescribe medicines. So they would do like the cognitive behavioral therapy and then maybe refer you to a psychiatrist to get, say, an antidepressant for something. So with that, with the PsyD, as well as even some master's level, I believe, are able to do this in some states, that if they go through specialized training on specific psychiatric medicines, so essentially the same courses that the psychiatrist took, specifically for the medicine, in some states now they can, psychologists can prescribe medicines. So check and see if that's the case where you live, and if your psychologist that you're seeing or one that you might think about seeing is able to prescribe medicines. Oftentimes a psychologist will have a psychiatrist that they know well and that they know works with your insurance, and so they'll be able to just refer you to that person to get a medicine, even if they're not able to prescribe it themselves. So a psychologist is going to be doing a general meeting with a psychologist. Might be more like an hour, 40 minutes to an hour. You'll sit down with them, talk about how things are going. They might even ask about any medicines you are taking. But most of the time will be, say, learning new skills to combat anxiety, or learning new coping mechanisms, learning anger management techniques. So learning new skills, doing the therapy, talking about things, that will be what you spend your time with a psychologist doing. All right, so psychiatrists, so back here to this left side, so again, they're the ones that prescribe medicines generally. They're usually working on a hospital premises, not always though. And if you're wanting to go into this field, generally with the medical degree as well as the ability to prescribe medicines, they're able to charge more for their services, so you're generally paid more as a psychiatrist than a psychologist. So with that, a psychologist, you might work connected to a hospital, but you might not. Oftentimes you'll have a separate clinic, and they tend to earn less than a psychiatrist. So yep, that is the way it works. So here are all those points just in one slide. It's there for ease of study. All right, so let's continue on. So what we will do first is define, how do we decide when is a behavior abnormal? How do we decide, is this behavior just a little bit different, or is this actually an abnormal behavior? So there are three key pieces to this. So we've got behavior that's deviant or atypical in some way, maladaptive or dysfunctional to the person and to others around them, and then personally distressing. So distressing to the individual, or maybe distressing to other people around them as well. All right, so when we're talking about deviant or atypical, what we're saying there is that it's statistically unusual. So a behavior that's different from the average. So with that, and that is also very much compared to cultural norms. So something that might be a strange behavior here in the US might not be a strange behavior in India. Something that's within the norms in India might not be within the norms here in the US. I'm imagining, I mean, this isn't exclusive to India by any means. This happens even in the US, but people climbing on the top of a train, for example, to get to work, because the train inside is so packed, so they're climbing on top of it, is something that does happen in India. It also happens here, packed subway trains, things like that. So that's just the first thing that came to my mind. Not real. You might see that behavior. Climbing on top of a train might seem a little deviant or atypical, but within the norms, it's pretty average. So with that, it also needs to be maladaptive and personally distressing as well. So it can't just be a deviant behavior, an unusual behavior. It also has to be distressing to the individual or the people around them, and maladaptive to their lives. So when we're talking about maladaptive or dysfunctional, it's disrupting someone's ability to lead a satisfying life. So whether that's determined by themselves or their doctor or peers, they have to see these behaviors and these symptoms as being maladaptive to the person's life. So are they able to go to work? Are they able to interact with their family? Do they hang out with their friends? Those kinds of things. If it's interfering with normal functioning, and especially if it's putting themselves or others in danger. Those are all critical things you might look for to see if a behavior is maladaptive. So, additionally, a behavior, to be an abnormal behavior in psychology, it needs to also be personally distressing. So over a long period of time, and the time span depends on the disorder. So depending on the disorder, the symptoms can be personally distressing in a really short period of time. Or it might take months to see that, oh yeah, this is really distressing, and it's been really distressing for a long time. It really depends on the criteria of how you diagnose a disorder. And we'll talk about some of the diagnosis criteria for each of these disorders. So with that, if you have certain patterns of behavior that are making you feel guilt or shame or despair, those are the kinds of things that we're talking about for personally distressing to you. So people with OCD, for example, oftentimes these compulsions are really distressing to them. They don't like having to do this same repetitive action every time something triggers them, right? And so that's really distressing to them. It might impact their ability to get to work. So we've got the distressing piece, we've got the maladaptive piece, and in atypical behavior, maybe that compulsion is an atypical behavior. A common one that's used as an example is washing hands. Washing hands 4 times every time you use the restroom or something like that. Just as a random example I thought of. So you need to have that deviant or atypical behavior. It also needs to be dysfunctional. It also needs to be personally distressing. And then we'll qualify it as an abnormal behavior. So, just like at the beginning of this course when we talked about theoretical approaches to psychology in general, each of these theoretical approaches are relevant to disorders specifically as well. So the biological approach is also called the medical model, and so this is a really, especially in the US, this is a really powerful, or not powerful, this is a really popular, that's a better word for it, popular approach to looking at disorders as a medical model that all of these disorders might have or probably have a biological origin. So if you're coming from this perspective, you're assuming that any disorder you're looking at probably has some biological origins in how it starts, how it develops, or how you could treat it. So the psychological approach focuses on a person's individual thoughts, their experiences, their emotions, their personality. So it takes all of those pieces into account. And then the sociocultural approach takes the social context into account. So is this an abnormal behavior in this culture? Is it an abnormal behavior for this person in this kind of setting that they're in their life? Is it maladaptive to them? Is it distressing to them? Why? Based on the social context. And the biopsychosocial model is all those words combined into one word, biopsychosocial. And that's because it's a perspective that takes all 3 of those and mushes them together. So we've got the biological, psychological, and social. So with that, it's an example of a model that's taking all these, trying to look a little more holistically. So a lot of the investigation into the how any disorder exists or how it develops does focus on the biological approach. Part of that is because that's kind of been a current in the US for a while, and the Diagnostic Statistics Manual that we'll talk about in just a minute focuses on the biological approach. I guess I should probably point this way, because then on the camera on your screen I'm pointing towards the slides, versus for me in my seat it's over here. Mirroring things. So the DSM-5 is the current classification system that we primarily use in the US. Some other countries do have different ones, but this is the primary one used in the US. So any psychiatrist, any psychologist will have learned a lot about this as they were training to treat. So it was published, the 5th one, so there were obviously a couple more before that. The 5th was published in 2013. Since then they have updated it. It doesn't look like they're going to be publishing, based on the most recent things that they've said, it doesn't look like they're going to be publishing a DSM-6. What they're doing is just revising sections of it in accordance with new research. So the DSM-5 that you would, let's say, print or download or pick up today would be different than the one from 2013. So new treatments, new research, so updating those sections is what they've decided to do since then. So there are other classification systems. So the World Health Organization has one, and the International Classification of Diseases and Related Problems, the ICD-10, that's its 10th version. So that one's used by a lot of other countries. So some of them have different advantages and weaknesses. The advantages of having the DSM-5, of having a classification system, of in some cases a literal book that you can take and open and look at and can compare symptoms on, is that it gives a good way to communicate about disorders. So if I am getting treatment with a psychologist here and I'm moving a couple thousand miles away and I don't want to keep doing therapy with that person, or more likely the insurance isn't going to let me continue to do therapy with that person, I have a new insurance in a new state with a new price and new providers that I can go to. the first provider can then send and say, hey, they meet these criterias in the DSM-5. I diagnosed them with this. These were the treatments that we were doing. It makes it a lot easier for therapist number 2 to take that, look at it, and understand what the therapist is talking about when we have a common language around that. So it can also help clinicians make predictions about things. So if you have these symptoms, it could be maybe this disorder, or this disorder. So you've got options 1, 2, and 3. So if it's options 1, if I do this treatment, it might be this one might improve, but if I do this treatment, these 2 might improve. So it can help them predict and then start to treat and also narrow down. So it's a way to help with the diagnostic process. And naming the disorder for the individual getting treatment can be really helpful. So we talked about how this can be really personally distressing for people with symptoms. So with that, if they have been struggling with problems, if they've been really anxious and really uncomfortable with the things that they're going through, and then they get a name to it, they have a name. Going to the example earlier, they're diagnosed with obsessive compulsive disorder. Now they have a name. They're like, okay, I can look this up, I can read on this, I figure out what this disorder is, and I can find treatments for it. And the psychologist can help me find treatments for it. And so naming it can help a lot. With that, some disadvantages of this are stigmas. So there is a lot of stigma for psychological disorders. So if you hear that someone has schizophrenia or borderline personality disorder, your first initial reaction might be to be scared or worried about them. It really shouldn't be, but because usually we only see people like that in, say, film and movies, and they're generally like a villain or the person doing a crime, that is the stigma that we have of these disorders. So there's also, well, we'll talk about stigma at the end of the lecture. I won't go too much into it now. Otherwise, I'll have nothing to talk about at the end. So with that, the DSM-5, one of what I think is one of its biggest weaknesses is that it does focus on psychological disorders as medical illnesses, that there's a biological cause to these, and there's a biological fix to all of them. It has a really big focus on the biological component, and that's one thing that continues to perpetuate that biological model as opposed to the biopsychosocial model. So the more inclusive model, I think, is a better one, but the DSM-5 doesn't include especially a lot of the sociocultural piece. That's often just kind of left out of there. So with that, it also focuses on people's weaknesses. So these symptoms cause people XYZ problems. We'll talk about some things, and you'll see some people with certain disorders that they've been diagnosed with that talk about them as maybe even having strengths because of them. I just saw a bit of research today that showed that people with ADHD, for example, while they might have trouble with attention, they actually do better on creativity tasks and thinking divergently. So looking at one problem, they're able to think of more solutions than someone who doesn't have ADHD, so someone who's a little more neurotypical. So the DSM-5 doesn't focus on that possible positive that you can emphasize and you can maybe work with a person with ADHD, especially if they're having anxiety about those symptoms that are problematic to them. Say, hey, well, maybe you can do this better and use that in your life, right? It also does seem to, and it does promote overdiagnosis. So with that, if you've got to meet 7 of these 10 criteria to be diagnosed with depression, maybe that makes it a little easier to diagnose with depression. However, it is useful still to have those common terms and criteria that we can talk about between therapists. It's also in some ways very subjective and culturally laden, especially with US values and culture. So you might be seeing, yeah, that's the right way, my cat over here. This is River. So hi, River. Probably up here in some of the video. Decided to sleep on that chair when I started the lecture. All right, so let's watch an example of a person who was diagnosed with a disorder, the stigma that they experienced, their own perspective, the anxiety they felt with that. So think about what we were talking about of when you diagnose something as abnormal. So we'll watch this. Since this is recorded and going up on YouTube already, you can watch me and this video at an accelerated speed if you click on the settings, make it go faster. So I'll actually record it right now at normal speed. In a classroom I might play it a little quicker, but in this context I don't want you to have it too fast for you if you don't actually want it that fast. So feel free to speed this video up as we go through this video, but I'm going to watch it at normal speed. Okay, here we go. I was going to say, assuming my internet wants to be fast. Like, I thought I only had these problems when I do broadcasts. No, clearly. Clearly sometimes it wants to happen just by itself anyway. Alright, I'll let it buffer just a second, then I'll turn it back on. But again, look for things like this person's own lived experience, how they experience these symptoms, their treatment path, yeah, a lot of things that we have talked about, and I hope you keep this video in mind as we talk about disorders throughout this as well.
The day I left home for the first time to go to university was a bright day, brimming with hope and optimism. I'd done well at school, expectations for me were high, and I gleefully entered the student life of lectures, parties, and traffic cone theft. Now, appearances, of course, can be deceptive, and to an extent, this feisty, energetic persona of lecture-going and traffic cone stealing was a veneer, albeit a very well-crafted and convincing one. Underneath, I was actually deeply unhappy, insecure, and fundamentally frightened. Frightened of other people, of the future, of failure, and of the emptiness that I felt was within me. But I was skilled at hiding it, and from the outside appeared to be someone with everything to hope for and aspire to. This fantasy of invulnerability was so complete that I even deceived myself. And as the first semester ended and the second begun, there was no way that anyone could have predicted what was just about to happen. I was leaving a seminar when it started, humming to myself, fumbling with my bag, just as I'd done 100 times before, when suddenly I heard a voice calmly observe, "She is leaving the room." I looked around and there was no one there, but the clarity and decisiveness of the comment was unmistakable. Shaken, I left my books on the stairs and hurried home, and there it was again. "She is opening the door." This was the beginning. The voice had arrived. And the voice persisted. Days and then weeks of it, on, narrating everything I did in the third person. She is going to the library. She is going to a lecture. It was neutral, impassive, and even, after a while, strangely companionate and reassuring. Although I did notice that its calm exterior sometimes slipped, in that it occasionally mirrored my own unexpressed emotion. So, for example, if I was angry and had to hide it, which I often did, being very adept at concealing how I really felt, then the voice would sound frustrated. Otherwise, it was neither sinister nor disturbing, although even at that point, it was clear that it had something to communicate to me about my emotions, particularly emotions which were remote and inaccessible. Now, it was then that I made a fatal mistake, in that I told a friend about the voice, and she was horrified. A subtle conditioning process had begun. The implication that normal people don't hear voices, and the fact that I did, meant that something was very seriously wrong. Such fear and mistrust was infectious. Suddenly, the voice didn't seem quite so benign anymore. And when she insisted that I seek medical attention, I duly complied, and which proved to be mistake number 2. I spent some time telling the college GP about what I perceived to be the real problem: anxiety, low self-worth, fears about the future, and was met with bored indifference until I mentioned the voice, upon which he dropped his pen, swung round, and began to question me with a show of real interest. And to be fair, I was desperate for interest and help, and I began to tell him about my strange commentator. And I always wish at this point the voice had said, "She is digging her own grave." I was referred to a psychiatrist who likewise took a grim view of the voice's presence, subsequently interpreting everything I said through a lens of latent insanity. For example, I was part of a student TV station that broadcast news bulletins around the campus, and during an appointment, which was running very late, said, "I'm sorry, doctor, I've got to go, I'm reading the news at 6. Now, it's down in my medical records that Eleanor has delusions that she's a television news broadcaster." It was at this point that events began to rapidly overtake me. A hospital admission.
So hopefully already, even just a couple minutes into this, you can see some of the things that we've talked about. So the distress from this symptom, so the symptom of hearing voices, symptoms of anxiety, symptoms of low self-worth. So at this point, they are becoming personally distressing. Right? So the first time she heard the voice, for example, she was distressed, but then it became kind of just part of life. It wasn't that distressing. It wasn't really impacting her ability to go to school, go to class. But then, especially after talking to a friend who reacted in this way with a lot of fear and worry, it seemed to start kind of a downward spiral. And then, especially when talking to some professionals, so the first sounded like a guidance counselor of some sort, about the problems, then being referred to a psychologist. So it sounds like the guidance counselor's maybe just having a bad day, and doesn't really, and was kind of out of it. But then when I heard some interesting symptoms like hearing voices, a lot of students, for example, me as well, when going through Psych 111, are really interested in like the I don't know a better word to say, the more unusual abnormal disorders, or because they're more out there or strange to us. And that's how I felt. I was like, oh, I really want to know more about schizophrenia. That sounds so interesting and so out there. So I had that stigma, right? And that's pretty common, even for, sounds like this guidance counselor. And then going to that professional who maybe she should have gotten a second opinion to see which other therapists might be good for her. As we'll talk about in chapter 13, one of the biggest keys for therapy being effective is having a good relationship between the therapist and the patient. So with that, that means the patient knows and believes that the therapist is trying to help and encourage them and pull them to do better. The patient wants to do better. So those are key pieces that sound like might have been missing with this first professional that she was seeing, who was interpreting all these symptoms as being really negative and leading to, without any choice, leading to negative outcomes. And then even interpreting things like, oh, she does do the news in a school setting, maybe not the like big nightly news, but like a small news broadcast, she does that, interpreting that as a symptom. So we'll see how this goes on.
Followed, the first of many. A diagnosis of schizophrenia came next, and then, worst of all, a toxic, tormenting sense of hopelessness, humiliation, and despair about myself and my prospects. But having been encouraged to see the voice, not as an experience, but as a symptom, my fear and resistance towards it intensified. Now, essentially, this represented taking an aggressive stance towards my own mind, a kind of psychic civil war. And in turn, this caused the number of voices to increase and grow progressively hostile and menacing. Helplessly and hopelessly, I began to retreat into this nightmarish inner world in which the voices were destined to become both my persecutors and my only perceived companions. They told me, for example, that if I proved myself worthy of their help, then they could change my life back to how it had been. And a series of increasingly bizarre tasks was set, a kind of labor of Hercules. Started off quite small, for example, pull out 3 strands of hair, but gradually grew more extreme, culminating in commands to harm myself and a particularly dramatic instruction. You see that tutor over there? You see that glass of water? We have to go over and pour it over him in front of the other students. which I actually did, and which needless to say did not endear me to the faculty. In effect, a vicious cycle of fear, avoidance, mistrust and misunderstanding had been established. This was a battle in which I felt powerless and incapable of establishing any kind of peace or reconciliation. 2 years later, and the deterioration was dramatic.
So with this, if she did not have that diagnosis, she might not have any kind of context to understand what was happening. This same kind of symptom might be happening to someone else, even currently right now, today, and not realizing that it is a symptom of a disorder and could be treated. Maybe not the best example of treatment up to this point in the story, but let's see how it plays out.
Now I had the whole frenzied repertoire. Terrifying voices, grotesque visions, bizarre, intractable delusions. My mental health status had been a catalyst for discrimination, verbal abuse, and physical and sexual assault. And I'd been told by my psychiatrist, Eleanor, you'd be better off with cancer, because cancer is easier to cure than schizophrenia. I'd been diagnosed, drugged.
So, pretty good example that maybe you should see another doctor in that case. I mean, I guess I could see that statement being used in a context where it could be like followed by something really inspirational, but clearly she's not taking it as something inspirational. Like, it's easier to cure cancer, but you can do it. Like, we'll do X, Y, and Z and you'll get better, right? Like, that could be an appropriate way to bring that up in that kind of situation. So with that, just like with a doctor, getting a second opinion, having a try with another therapist is a good idea as well. Also, some of the problems that she encountered because of stigma, so that having the disorder left her open to additional problems and even abuse. So this is actually a really common phenomena for a lot of people that have diagnoses of mental disorders. So just keep that in mind as we cover all the disorders, and then we talk about how we can maybe help with stigma at the end of this chapter.
Guarded, and was by now so tormented by the voices that I attempted to drill a hole in my head in order to get them out. Now, looking back on the wreckage and despair of those years, it seems to me now as if someone died in that place, and yet someone else was saved. A broken and haunted person began that journey, but the person who emerged was a survivor and would ultimately grow into the person I was destined to be. Many people have harmed me in my life, and I remember them all, but the memories grow pale and faint in comparison with the people who've helped me. The fellow survivors, the fellow voice hearers, the comrades and collaborators. The mother who never gave up on me, who knew that one day I would come back to her and was willing to wait for me for as long as it took. The doctor who only worked with me for a brief time, but who reinforced his belief that recovery was not only possible, but inevitable. And during a devastating period of relapse, told my terrified family, don't give up hope. I believe that Eleanor can get through this. Sometimes, you know, it snows as late as May, but summer always comes eventually. 14 minutes is not enough time.
So a really good example of a good doctor who is, and I guess we don't know everything about the doctor. But yeah, good example of maybe some good doctor practices versus poor doctor. And it seems, as you can see, that they're with that doctor and other professionals and help from family, that this kind of started a positive upward spiral for Eleanor.
I'm to fully credit those good and generous people who fought with me and for me and who waited to welcome me back from that agonized, lonely place. But together they forged a blend of courage, creativity, integrity, and an unshakable belief that my shattered self could become healed and whole. I used to say that these people saved me, but what I now know is they did something even more important in that they empowered me to save myself. And crucially, they helped me to understand something which I'd always suspected, that my voices were a meaningful response to traumatic life events, particularly childhood events, and as such were not my enemies, but a source of insight into solvable emotional problems. Now, at first, this...
So she's talking there about reframing her understanding of the symptoms of the voices, that they gave her insight into the trauma that was triggering them. They gave her insight into her own emotional responses to situations. This is one thing that probably came through especially cognitive behavioral therapy. So keep that in mind, kind of the words that she's using, and that is essentially what one big piece of cognitive behavioral therapy does, is to reframe some of our thoughts around symptoms of disorders.
This was very difficult to believe, not least because the voices appeared so hostile and menacing. So in this respect, a vital first step was learning to separate out a metaphorical meaning from what I'd previously interpreted to be a literal truth. So, for example, voices which threatened to attack my home, I learned to interpret as my own sense of fear and insecurity in the world rather than an actual objective danger. Now, at first, I would have believed them. I remember, for example, sitting up one night on guard outside my parents' room to protect them from what I thought was a genuine threat from the voices, because I'd had such a bad problem with self-injury that most of the cutlery in the house had been hidden. So I ended up arming myself with a plastic fork, like picnicware, and sort of sat outside the room clutching it and waiting to spring into action should anything happen. It was like, don't mess with me. Got a plastic fork, don't you know? No, it's strategic. But a later response, and much more useful, would be to try and deconstruct the message behind the words. So when the voices warned me not to leave the house, then I would thank them for drawing my attention to how unsafe I felt, because if I was aware of it, then I could do something positive about it. But go on to reassure both them and myself that we were safe and didn't need to feel frightened anymore. I would set boundaries for the voices and try to interact with them in a way that was assertive yet respectful, establishing a slow process of communication and collaboration in which we could learn to work together and support one another. Throughout all of this, what I would ultimately realize was that each voice was closely related to aspects of myself, and that each of them carried overwhelming emotions that I'd never had an opportunity to process or resolve. Memories of sexual trauma and abuse, of anger, shame, guilt, low self-worth. The voices took the place of this pain and gave words to it. And possibly one of the greatest revelations was when I realized that the most hostile and aggressive voices actually represented the parts of me that had been hurt the most profoundly. And as such, it was these voices that needed to be shown the greatest compassion and care. It was armed with this knowledge that ultimately I would gather together my shattered self, each fragment represented by a different voice, gradually withdraw from all my medication and return to psychiatry. Only this time from the other side. 10 years after the voice first came, I finally graduated, this time with the highest degree in psychology the university had ever given, and 1 year later, the highest master's, which I always say isn't bad for a mad woman. In fact, one of the voices actually dictated the answers during the exam, which technically possibly counts as cheating. And to be honest, sometimes I quite enjoyed their attention as well. As Oscar Wilde said, the only thing worse than being talked about is not being talked about. It also makes you very good at eavesdropping because you can listen to two conversations simultaneously, so it's not all bad. I worked in mental health services, I spoke at conferences, I published book chapters and academic articles, and I argued, and continue to do so, the relevance of the following concept, that an important question in psychiatry shouldn't be what's wrong with you, but rather what's happened to you. And all the while, I listened to my voices, with whom I'd finally learned to live with peace and respect, and which in turn reflected a growing sense of compassion, acceptance, and respect towards myself. And I remember the most moving and extraordinary moment when supporting another young woman who was terrorized by her voices, and becoming fully aware for the very first time that I no longer felt that way myself, but was finally able to help someone else who was. I'm now...
So, a really good example of now she's no longer distressed by the symptoms. So, would this be a full, complete cure? By the sounds of it, she still has some symptoms, but it doesn't sound like they're personally distressing. So, I mean, that's really what she was probably hoping for as she worked through this, especially in those times that it was darkest, that she's essentially, based on the average of people around, she's functioning as people should, essentially. So would that now be defined as abnormal or not? So think about that definition, see if you think that would fit. But also, I think it's also really inspiring and shows how the stigma and fear and anxiety and problems that you about any kind of problems or symptoms can lead to that negative downward spiral, versus support, care, the proper treatments can really help on that positive upward spiral too.
Very proud to be a part of Intervoice, the organisational body of the International Hearing Voices Movement, an initiative inspired by the work of Professor Marius Romm and Dr. Sondra Escher, which locates voice hearing as a survival strategy, a sane reaction to insane circumstances, not as an aberrant symptom of schizophrenia to be endured, but a complex, significant and meaningful experience to be explored. Together, we envisage and enact a society that understands and respects voice hearing, supports the needs of individuals who hear voices, and which values them as full citizens. This type of society is not only possible, it's already on its way. To paraphrase Chavez, once social change begins, it cannot be reversed. You cannot humiliate the person who feels pride. You cannot oppress the people who are not afraid anymore. For me, the achievements of the Hearing Voices movement are a reminder that empathy, fellowship, justice and respect are more than words. They are convictions and beliefs, and that beliefs can change the world. In the last 20 years, the Hearing Voices movement has established Hearing Voices networks in 26 countries across 5 continents, working together to promote dignity, solidarity and empowerment for individuals in mental distress, to create a new language and practice of hope, which, at its very centre, lies an unshakable belief in the power of the individual. As Peter Levine has said, the human animal is a unique being, endowed with an instinctual capacity to heal and the intellectual spirit to harness this innate capacity. In this respect, for members of society, there is no greater honour or privilege than facilitating that process of healing for someone, to bear witness, to reach out a hand, to share the burden of someone's suffering, and to hold the hope for their recovery. And likewise, for survivors of distress and adversity that we remember, we don't have to live our lives forever defined by the damaging things that have happened to us. We are unique, we are irreplaceable. What lies within us can never be truly colonised, contorted, or taken away. The light never goes out. As a very wonderful doctor once said to me, "Don't tell me what other people have told you about yourself. Tell me about you." Thank you.
So really good examples there too of socio-cultural treatment and direct action, really. Making networks of people with these same symptoms to support them. Sounds like outside of the systems that already existed, and then maybe connecting with the systems that already existed of doctors and getting people connected to doctors or other people as a support group that are feeling that are having those symptoms of hearing voices, as well as the idea that these kind of symptoms are a response to something, and that treating that core piece is a good way to reduce or minimize these symptoms that can be really distressing. So voices are not just a symptom of schizophrenia. So hallucinations and hearing, actually the most common hallucination is an auditory hallucination. So people who have hallucinations, more often they're having auditory hallucinations rather than visual hallucinations. And so essentially, you can get hallucinations from high fevers even. So hallucinations and hearing voices are not a symptom that's exclusive to schizophrenia. It's essentially, like they're saying, a sign of other things. Treat those core things. And so we can think back to the DSM-5. Yes, there are some biological relations and correlations with schizophrenia, and we'll talk about that in a minute, but that doesn't mean that the biology is the only cause of things. So that's one weakness of like DSM-5, is focusing so much on that biology and not looking at, say, the sociocultural factors and encouraging, say, sociocultural supports, things like that, which are hard. Like any different city is going to need different supports for the different people. Any community. So the streets I live on over here, these people probably need different supports than people 20 miles away in their neighborhoods. So I understand it can be harder to put that in a DSM-5 where you're trying to make it universal, because a lot of these things and a lot of treatments aren't necessarily, especially when we're talking about sociocultural treatments, are not necessarily going to be universal. So a little bit of a tangent there. But hopefully it made sense. We'll watch some of these other videos later on, but since we spent so much time with that one and connected it so much, I think we should learn a few more things about a couple more specific disorders before we watch another video. So let's continue with autism spectrum disorders, and we'll talk about neurodivergence. So autism spectrum disorders are classified as this big umbrella. So this bigger umbrella is autism spectrum disorders. You might have heard of some of these. Some of these names have changed now, but you might have heard of them. So like Asperger's, you might have heard of that. It's not a name that's used as much now. So autism spectrum is more the common term. So these are deficits in communication and social interaction. So restrictive or repetitive behaviors. So common kind of either tics or repetitious kind of actions or series multiple actions on repeat, and interest in activities as well that might be restrictive or repetitive. So as you can see there, the focus is again on some of the negative aspects of autism spectrum disorders. So with that, these range from more severe autistic symptoms to more milder Asperger's syndrome. So with that whole spectrum, you can imagine it going from more neurotypical, which is like an average brain. An average human's brain, you could say, is neurotypical. It's operating and the cognitions are going in the typical manner, versus someone who has severe autistic symptoms. Their brain is working in a very much different way. Maybe the sensations that they're receiving are different, the way they're interpreting things is different, versus someone with Asperger's. You might look at that person and say, well, you might say they're pretty normal, they're pretty close to neurotypical. So essentially, the autistic spectrum, you've got a range from close to neurotypical to further away from neurotypical. So with that, any autism spectrum disorder, or a really common symptom, is sensitivity to sensory information. So that's any senses, so light, sound, touch, and oftentimes it's specific kinds of sensory information. So with that also, there tends to be on average lower levels of executive functioning, and specifically in working memory. Remember, working memory is that mental workbench where we're calling up long-term memories, where we're interacting with things right now today. So imagine that plus a little bit different sensory input coming to your workbench. Your responses might be a little different, right? So with this, it's usually identified in early and mid-childhood. There's a lot of efforts to try and identify autism spectrum disorders really, really early on. And that can be really good to identify them earlier on. I just wonder when we're going to hit that point of diminishing returns on how early can you really detect autism. So some of my colleagues are even trying to look like 1.5-year-olds and seeing if there's common symptoms there that they can trace to later on diagnoses. So with that, autistic disorder is a severe developmental disorder. A lot of times there's abnormalities in communication. They might not even be verbal, for example. There's often restricted or repetitive patterns of behavior. So doing, say, the same hand motions. I'm waving my hand, so it makes sense to use that as an example. Or repetitive patterns of behavior. So they very frequently go to this spot and then go to this spot and then do this thing or something like that. It often affects social relationships poorly because since their brain is working differently than a neurotypical person, they're doing this restrictive pattern or this they're having these different sensory input. Their mental workbench is slightly different, so they're their inputs are a little different, their outputs are a little different, their focus on social cues is a little different, and their understanding of social cues might be different. So that can be hard for that person who's experiencing this, as well as maybe a neurotypical person, to interact with each other. Because they both are kind of experiencing a different way or know a different way to talk to each other. So Asperger's syndrome, relatively good language skills here, so usually verbal. You might think of examples in TV or movies, or even family members that might have Asperger's. Generally, this is still on the autism spectrum, but since it's closer to neurotypical, it's not seen as as bad, which is part of the stigma for it. Still, there are often nonverbal language problems, so maybe problems picking up on nonverbal cues, not understanding, say, well, we're talking specifically about nonverbal, so not picking up on some facial expressions or quick facial expressions, or tone of voice changes, those kinds of things. Oftentimes still repetitive routines or preoccupations with particular subjects. One client I worked with who was on the autism spectrum, he had a preoccupation with animals, not animals, insects are insects classified as animals? Anyway, I don't believe so. The point here is a preoccupation with insects that live in hives and big groups, like ants, bees, wasps, termites, things like that live in big groups. He had a preoccupation with that. So, what are some causes of autism? Well, there are a couple different ideas. One of the ideas is the cognitive approach. How are you processing things cognitively? Maybe that is leading to autism symptoms. So one of the ideas is that there might be a deficit in the theory of mind, and we talked about this really early on in class. Essentially, the theory of mind is that you understand that you are a different individual as another person, and you have your own unique subjective experience. Maybe there's a problem cognitively with the theory of mind of people who are on the autism spectrum, so they aren't grasping the other people's having different subjective experiences as opposed to them. So with that, if they don't have that clear theory of mind, or it's not as well developed, that might impact their social interactions. They might not be picking up on the nonverbal cues from someone, or understand that that person has maybe a different perspective than them, and so that can make it really hard to then communicate together, so because their brain is working differently. So is that a cause or a consequence of their development? So does that cause the autism, or did the autism symptoms lead them to that point where they now don't have as good theory of mind? And as an example, the next slide talks about, I think it's the next one, yeah, the social motivation approach, that some of the sensory inputs, say from facial expressions, that someone on the autism spectrum might not be as attuned to that sensory input of a facial expression, and then as they're growing up from an infant, if they're not that attuned, they're not having the same interactions, they're maybe not learning theory of mind as well as someone who is attuned to that. So which of these are the causes or consequences of autism? That is difficult to figure out. So, social motivation approach. It seems that people on the autism spectrum have less interest in some social stimuli, and that might be a sensation thing, that, say, feature detectors. We've talked about those for faces and emotions. Maybe those feature detectors aren't working the same or as quickly, or something like that. So that does, though, change what they attend to and what they experience. So as an infant, if you're not going to be attuned to a face, you're not going to care so much about the game of peekaboo, as an example. So your lived experience will be different than someone who does have more interest in social stimuli. So is that symptom a cause or a consequence of an autism spectrum disorder? That's not super clear, but it does mean that a person on the spectrum has a different lived experience and essentially a different developmental trajectory. So if we think about the developmental cascades model, they're experiencing a different cascade than someone with maybe a more neurotypical development. So another idea is the sensory processing approach. So it's very clear that people who are on the autism spectrum do experience sensations differently. So more intensely, maybe with more fear to some of them, maybe certain sensations, maybe a certain kind of touch or a certain kind of smell or a certain kind of lights or flashing or colors. It is being sensed differently and perceived differently in a way that is sometimes distressing. So with that, there's also more focus on fine details. And if you're highly sensitive to the sounds or lights or certain tactical sensations, you might not be organizing those sensations cognitively in the neurotypical way. So again, your experience, your lived experience for someone on the spectrum is a little different than a neurotypical person. If your sensations of light or sound or some tactile senses are a little bit different, especially if these other things are possible causes too, all those combine together so that a person on the autism spectrum is living a very different life than a more neurotypical person. But that's because their brain is working a little bit differently. And so now a more recent word is neurodivergent. So there's neurotypical, like closer to the average of the way people think. Neurodivergent is, hey, my brain is working slightly differently, and the point of neurodivergence is that that's not necessarily a bad thing. So, what are some other possible causes of autism before we talk about neurodivergence? I think we're actually talking about ADHD as well before neurodivergence. Well, let's continue. So it also seems that it's correlated with abnormalities in the brain structure and neurotransmitters. So did these brain structures grow and develop to that way or change over time? It's different for different parts. So lack of connectivity between different brain areas. And so is that genetically encoded, or is that because of prenatal experiences? Is that because of not focusing on the same kind of stimuli, that there's not as much dendrites and axon branches connecting between two areas? But with these, there are genetic factors that seem to be an increased risk for autism spectrum disorders. So treatments. There is a lot of research on treatments for autism spectrum disorders. A lot of these focus on education and schooling of children with autism spectrum disorders, and all of these recommendations also help for neurotypical children as well. So a structured classroom. So having a structured classroom where they know and the pattern's the same. That can be really helpful. Individualized teaching, this is one that's really helpful for anyone. If you have one-on-one teaching or the fewer students per teacher, the better. So if a teacher is teaching 3 students on the autism spectrum and 5 neurotypical students, that's a total of, I forget what I said first, I'm at 8 students now. That's better than if that same teacher has, say, 30 students and 3 of them might be on the autism spectrum and the rest of them are neurotypical. Small group instruction can be really helpful, and behavior modification techniques. So this is what we're talking about. I've mentioned ABA therapy a couple times, probably because I've done it. But ABA therapy can be really helpful for people on the autism spectrum. All right, yep, we're going to cover ADHD. Then we'll watch a video that goes over a person that talks, where we see a person on the autism spectrum, talk about it, and then talk about neurodivergence. So, ADHD, the diagnostic criteria, like if you looked in the DSM-5, you would see criteria for inattention, hyperactivity, impulsivity, and like different symptoms you might see that you say, oh, yep, they're checking off impulsivity, they're checking up hyperactivity, they're checking up inattention. So inattention, difficulty focusing on one thing. So one thing being like a lecture or a puzzle or a game, getting bored, only able to stay on task a few minutes. That's inattention. Hyperactivity is essentially high levels of physical activity. So if you see someone doing a lot really quickly, running around a lot, that's a higher level of physical activity. With that being said, this is where we go back to, is this abnormal? So if you take a 5-year-old child, they'll probably be running around a lot, right? So if you take that 5-year-old child and put them in a kindergarten where they're supposed to be or expected to sit still for an hour at a time, that might be difficult, but that might not be abnormal, right? So there's that line, like, is this abnormal or is this not abnormal behavior? So, and is it personally distressing? Is it maladaptive? It might be maladaptive in that kind of classroom setting, but is that also atypical? It's not really atypical for a kid to be running around and playing. So that's hyperactivity. Impulsivity, difficulty curbing actions or reactions, so being quicker to react, seemingly not to think before acting. So that's also another example of something that's pretty common in early childhood. So we've talked about many times in this class how the prefrontal cortex doesn't finish its myelination until about age 23. And so even as an adolescent, it's pretty common to see quick acting on emotions in adolescence, right? And in childhood, they're still learning the process of regulating emotions, not reacting, things like that. So, so the diagnostics for this, you've got the DSM-5. You're trying to decide, okay, are these behaviors, especially in a young child, are these indicative of ADHD or not? So that makes it hard to diagnose in some cases. With that, about 9 times more boys than girls are diagnosed with ADHD. So there are disagreements over the reason for the increasing frequency of diagnoses. So in the last decades, there has been more and more cases diagnosed of ADHD. Is that because we're overdiagnosing it? Is that because now we have clear symptoms and names for these things? Maybe both. So with that, students with ADHD have a risk. It's a risk factor for lower academic achievement, underachieving in math, reading, higher chance of substance abuse, and a high correlation with antisocial behavior as well. So ADHD is another example, and we mentioned this a little earlier, that I just read a study about how people with ADHD, while they might have these symptoms of inattention, hyperactivity, and impulsivity, their brain is working a little bit different. They're also neurodivergent, but that divergence can make them better in some cases at doing creative problem solving. So that's a good thing versus there's these other things. So yeah. With that, there might be genetic tendencies to develop ADHD. You'll see that with a lot of these. There's a lot of investigation because of that focus on the biological framework of psychology as well as disorders to look into what are the biological components of these. Brain damage pre- and postnatal can lead to ADHD, and then the prefrontal cortex delays or having fewer connections in the prefrontal cortex, so essentially having as well as decreased myelination, so having less connectivity in the prefrontal cortex, and so that's the area where it's not the only area responsible for like stopping and thinking about our actions, but it's one of the big ones. And it's one of the ones that's still growing and developing and changing and getting a lot better at that in childhood and even adolescence. Neurotransmitters dopamine and serotonin might play a role as well. This is one reason that a lot of times antidepressants are used to treat ADHD. So see, there's a lot of things antidepressants are used for. Also, prenatally, teratogens do have higher correlation with ADHD, and yeah, we talked about most of these things. So also cognitive difficulty with those executive functions, those things in the prefrontal cortex, short-term memory, regulating emotions, and delaying gratification. All right, so with ADHD, stimulants are often used, so that might seem a little counterintuitive. So you've got someone who is hyperactive, why would you give them a stimulant? Why would you give them Ritalin or Adderall? Because it does seem to be effective at improving attention ability. In the classroom setting, you can take those. With those medicines, a lot of the stimulants, they have to be taken at very, very regular intervals. It actually talks about this in the example question paper that I have that you may have looked over near the beginning of the class. But these stimulants, they have to be taken at very regular intervals. So some of them are in as short spans of times as like 4 hours. Some of them are like 6 or 8 or 12 hours. And so that can be really hard for a child in school. So in a school setting, if they have to go to the nurse and get their medicine at the same time every day, like they can get in the pattern, obviously. But as a kid, you might want to play instead. So, and if you're missing it, then it's a really quick, the symptoms come back really quick. So if you miss it, like half an hour later, you might even start to see symptoms already of that hyperactivity. So behavior management helps a lot in combinations with the drugs. So whether that's ABA therapy, learning behavior management, cognitive behavioral therapy, learning behavior management. So behavior management can really help to learn how to regulate emotions, to calm down, to stop and think before acting, to reduce those symptoms. Neurofeedback especially, learning skills about how the brain processes info. So learning what your brain is doing would help a person who is neurodivergent learn, I can use my brain in X, Y, and Z ways. Similar to how we talked about for the memory chapter, I learned that I need to take more frequent breaks than maybe someone with a more neurotypical brain might have to do in doing my studying, my writing, things like that. Honestly, I would take more breaks during recording lectures, except I really dislike editing videos together. Mostly because my processor is slow, and so it takes a long time to do that. So it's just easier to power through than to wait the extra time to let the computer work on the video and like render it, which seems very silly. Yeah, that is the truth there. Mindfulness can really help as well for ADHD. So focusing, essentially mindfulness, we've talked about it recently, focusing on your current experience. So if you're aware of your current experience, it might be a little easier to regulate your emotions, your impulses, those kinds of things. Physical exercise, we'll see how physical exercise helps a lot of different things. But especially aerobic exercise can really help with ADHD symptoms. So with that, this is the one I want to watch. There are a lot of video links as well as research links in this slideshow. They're a good place to start for learning more, for doing a question paper. For example, there's links later on for our section on PTSD. So that would be a good link to start off with if you're wanting to do a question paper in that area. But let's watch this with a broader or a bigger discussion of neurodiversity, because autism spectrum, ADHD, dyslexia, there's a lot of different things that we call disorders that might be better termed as neurodivergent. That yes, the brain is working a little bit differently, but is this necessarily a bad thing or something that people should be distressed about having those symptoms? So we'll talk about this individual's experience with their autism symptoms as well as their ideas around neurodiversity. So pay attention to those things. Guess I could have been letting it load as well while I was preambling it. Not sure if that's the right word, but that's okay.
My name is Elisabeth Wiklander, and I am autistic. What do you think about when you hear the word autistic? How do you react when you hear the word autism? Would you say that it is a lifelong disorder, an impairment, a disability? This is indeed the way medical language describes it, but autism is so much more than that. No diagnostic manual can truly explain the multifaceted experience of autism. It is a neurological difference with a vast spectrum of representation within its population.
It can come with remarkable gifts and skills, as well as devastating traits. But autism doesn't necessarily equal disability. And thankfully, today we have a word that challenges this negative terminology: neurodiversity. Neurodiversity describes how diverse we are as human beings from a neurological perspective. It suggests that the many variations of human brains, like autistic ones, should be accepted as a natural and valuable part of humanity's genetic legacy. DNA shows us that autism is primarily a genetic condition, something that has been passed down through generations and is still widely shared in the general population. These genes can carry some.
So our point there is that if these genes still exist, if people are still autistic and have been, maybe there's some socially adaptable evolutionary reason they exist. But another main point that she's bringing up, and I think you could see in the earlier discussion from Eleanor, is that people with disorders, they're also people. We should be inclusive of these people. We should be supportive of them in their symptoms and their challenges and their trials, and we can look at them not as people, especially when we're talking about neurodiversity here. Someone on the autism spectrum is not completely incapable of providing to society. They just might need to provide to society and interact with people in a slightly different way because their brain is working in a slightly different way. So essentially a big point there is inclusivity, and I think that goes to our discussion at the end of this chapter about stigma as well, in that we can be a more inclusive world for people who are experiencing these symptoms, just like we can be a more inclusive world for people who have limited mobility. So we have better door handles on buildings to help people with limited mobility, or we have wheelchair ramps, we have elevators, we have specific standards for building things. We can have specific standards, and we're getting to there where we have specific standards in classes, for example, that we have the disability student services that does a good job. It can help a lot, but I feel like there's more that we can do in that kind of area, just like we have buildings and we have Braille. As I walk down the street, I see at the corners the sidewalk raised with bumps, so if you're using I can't remember the actual name of the stick, but you can feel that and know, like, here's where the corner is, this is the direction you need to be facing, kind of thing. Sounds for people who are hard of hearing, for example. We can be more inclusive for people who are neurodiverse, as well as people who are experiencing symptoms of other disorders.
Things so positive, in spite of the difference they cause, that they have persisted throughout our evolution and still flourish today. Some of our important inventions, pieces of art and music, and discoveries in scientific fields that have moved our world forwards come from autistic minds. With today's exciting new technologies in neuroscience, we have seen that autistic brains differ from the norm. Not only that, but it appears as if each and every one differs in its own unique way. So, autism is rich in expression, but still faces limiting generalizations. Today, I want to talk about the autism that I display, the one that blends with normality and can have catastrophic impacts on people's lives, not necessarily because of the autism itself, but because of the ignorance of it, or the failure to recognize that it is there in the first place, as I eventually would discover. Now, in social situations, we do have expectations upon one another. We use a certain kind of rule book, which when followed, rewards us with social acceptance. But I always felt that I was different. The trouble was I couldn't explain how, and certainly not why. It felt as if I had been provided a different rule book, and that I lacked a community to fall back upon that could confirm to me that the way I interpreted the world was valid too. So I grew up feeling very misunderstood by pretty much everybody, even within my own family. If I applied what would have been my motives, my intentions upon someone else's behavior or vice versa, the outcome was often negative and very confusing. So to me, the social world became scary and unpredictable. Now, I did notice, however, especially during my school years here in Sweden, that my mind had been blessed.
So before we get into some of the positives she was noticing, I think this is a really great way to understand the descriptions we talked about earlier. So the neurodivergence of sensory inputs being different interpretation of social situations, different cues being important in her mind, as opposed to it might be for a neurotypical person. She didn't feel like the social rules that she was expected to follow really made sense. So her brain is literally working and processing a social situation differently than someone who's a little more neurotypical. So is that wrong? No, that's just the different way that her brain is processing this. So what does that mean? Well, it means that her brain is processing things a little bit differently. And let's see, a lot of those things we might say are negative, like if it's harder for a mother to communicate with her daughter or a father to communicate with daughter, or for her to communicate with siblings, like that can be difficult or might be seen as a really negative symptom. But let's see if it could have some positives too.
And unpredictable. Now, I did notice, however, especially during my school years here in Sweden, that my mind had been blessed with gifts, like analytical skills, an intense mental focus, high capacity for memorizing information, which made studying very pleasurable and easy. So in my academic pursuit, I came here to Gothenburg, where I studied at the university. I later went to the Netherlands, where I attained my Master of Music. And today, I live in the UK, working as a professional cellist in the London Philharmonic Orchestra, touring the world. But this, however, is quite unusual for me, to stand on a stage just talking to you without my instrument. I can't help the feeling that I have forgotten it somewhere. Okay, so one may now think, okay, she plays in this great orchestra. She's obviously done pretty well for herself. What's the problem? Well, I have a very literal mind. And it constantly clashes with both non-verbal and verbal subtleties in social situations. It gives me a very direct line of approach and speech in everyday conversations. I still don't really understand the purpose of small talk, although I can appreciate it now. And jokes and sarcasm fly completely over my head. My mind just takes things in so literally. It loves to analyze everything. My world is a very intense one. My senses are heightened. My brain absorbs everything in through an amplifier. My special interests can completely consume me. And my emotions, they go from the highest of high to the lowest of low, and they're on and off like a light switch. My family, bless them, they can still stand in utter disbelief when I go from a complete nuclear blast to rainbows and butterflies in less than 2 seconds, literally. So, okay, autism influences my thoughts, my imagination, my senses, my emotions, and the way I process information.
So hopefully you're picking up here. I kind of made this point earlier, but hopefully with these other descriptions of what she's experiencing, you can see how her sensations, her perceptions within social situations are different than maybe yours are. Maybe yours match up with hers if you're on the autism spectrum, but it also might be different even if you are on the autism spectrum. That's what neurodivergence is that people's brains work differently. We're unique in the way that our brains might work. There's some commonality, obviously, like the prefrontal cortex does planning and emotion regulation and things like that. But Is it working as much in me as opposed to someone else next to me? Those kinds of things. That's also not exactly neurodivergence, but it still is, in the sense of the word, neurodivergence as well.
But without knowing this, it was very difficult to maintain friendships because our social expectations were so different. I could come across as odd, and I experienced a good amount of bullying for it. But the most devastating were the eroding misunderstandings that dominated the relationships with the people closest to me. Body signals, misread. Words, completely misinterpreted. It was so frustrating. It was like fighting a ghost, something that no one could really grasp, not even the counselors we sought for help. So it was a mentally agonizing situation that persisted year after.
Personally distressing, so abnormal, part of that definition we talked about. So that would be, I guess I'll extend that point so it's not misinterpreted. So that personal distress about the symptoms would be one of those pieces in the definition of abnormal. It needs to be personally distressing as well as maladaptive as well as atypical. So got that personally distressing piece checked off there.
After year. And in my mid-20s, I had reached a really dark place. And I started to be truly scared for my future. But then, something extraordinary happened that changed everything. In 2006, I heard about Asperger's syndrome. It is already an outdated term today, but it is still a form of autism on the high-functioning end of the spectrum. 3 years later, when I was 28 years old, I received this diagnosis. And I realized that a good third of my life had been based upon a false perception of myself. Imagine that. No wonder my life had been so confusing. But now I started to see myself in a new, clear context. My whole life and all my experiences just started to make sense. This launched me on an incredible journey of enlightenment and transformation.
So a really good example of how getting your disorder labeled or having these symptoms labeled can help you understand things. So as she talks about, counselors that she went to originally, they didn't have any way to help or describe things. So that's one reason like DSM-5 can be really useful, is by having this common language, these check marks to check off and say, oh, yep, the symptoms you're experiencing fit well with Asperger's syndrome. So that's what we'll diagnose you with. She knows that. She can look it up. She can study about it and realize, oh, this explains a lot of my own personal experience. That can be really, really helpful and really comforting for a person.
I had finally been given something that allowed me to explore the relativity of my perception of the world compared to others. I gained access into that mysterious rule book, and I could start comparing it with mine. And so I learned to identify my differences. So in the coming years, I found efficient ways to improve my social skills. I learned to verbalize my needs, recognize my limitations, and develop my strengths. I founded successful strategies to navigate my everyday life and significantly improved all the disabling traits of my diagnosis. But this took a lot of commitment, dedication, and hard work. Because autism is a spectrum, I had to become like a researcher and collect a lot of information from a lot of different sources over a long period of time in order to be able to complete my unique life puzzle. When I thought that I had reached the level of conformity that society demanded, I kept feeling that something was not quite right.
So before she continues on with this point, I think it's a really good example that any given treatment or program or practice that is working specifically for her might not work exactly the same for someone who's even diagnosed on the autism spectrum close to her diagnosis, right? So the sociocultural factors, her own family upbringing, her own sensations and perceptions that are different from anybody else's are going to mean what works for her might not necessarily work for someone else. That's why, for me, as an example, for my study times, I need to take breaks about every 35 minutes of doing work, whether it's writing or something like really cognitively intensive. For some other person, it might be shorter than that, might be longer than that. So with any therapist, for example, or psychiatrist, you need to work with not just with neurodivergence, but all disorders that we're talking about today. There's a lot of possible kinds of treatments that can work. We watched a video on a treatment of phobias, and I'll call back that example later today too. So that might work for the person we watched weeks ago in classical and operant conditioning about how to desensitize yourself to those fear responses. So that might work for that person, but it might not work for another person who also has a phobia of snakes. So working with a therapist, family members, professionals, roommates, to try different strategies and different patterns to figure out what works for you specifically is a big part of the process of therapy. And that can take a long time. But hopefully through that time you're realizing there's a little bit of improvement being made all the time. Even just with a psychiatrist, trying one drug and then a different dosage of that drug, or two drugs together, or a different drug. It's the same kind of thing, like trying to figure out what works best for that specific individual. So there's always that aspect of, yep, on average, these things work. But for you specifically, this plus this will work best. And it's a matter of figuring that out for a lot of these disorders, not just her specific story, but everyone's specific story.
Something was still missing. I could change the way I acted, but I cannot change the way I am. My natural biological calibration is and always will be autistic. And the problem I had now was to live up to these new high social standards that I had set for myself. I had come to understand my differences. But as you all know, a relationship is a two-way street. Without acceptance and understanding for the real me, I would never be truly happy. And this prompted me to one day make quite a radical move. On the 2nd of April, 2015, I announced my autism on social media. And I started to talk about it with everybody. Openly, bang, just like that. I admit it was absolutely terrifying, because I had encountered what was out there, the stigma, the prejudice. I was very afraid that people would put their preconceived ideas of autism onto me rather than letting me show them what autism can look like. But this didn't happen. What happened was that my life changed completely, almost overnight. I was met with curiosity, and support started to flood in from everywhere, from friends, from family, from colleagues, and from people I didn't even know. Media started to take notice, and people who recognized themselves in my story started to contact me from near and far for help. Seeing how common the situation was, and how efficiently it could be reversed using the same tools that I had, it inspired me to share my experience further. That the knowledge of neurodiversity opens new communication channels between us by identifying differences we didn't know of before because they have been hidden in our minds. It unlocked my world with the key to identify my differences and to communicate these in a way that we could all understand. So today, I am a very happy person. I've got wonderful friendships. I've connected deeper with my family members. And I'm experiencing what it is to be in a happy, healthy relationship with a wonderful man, who's thankfully also very patient. Because misunderstandings, they still do happen. But now they can be resolved, so they're no longer a threat to our relationship. We have taught one another to read each other's rule books, and it is enriching both of our lives.
So I definitely would recommend watching the rest of this video as well, but I think we got the main points that I wanted to point out as a really good example of the experience of an autism spectrum disorder, as well as a lot of examples of things that we're talking about already and things we'll talk about in the rest of the class today. So let's talk about the next disorder. We'll jump into anxiety-related disorders. I think I may have just accidentally made my camera take a picture of me, which is fine. So, anxiety-related disorders. We'll talk about a couple different ones, and we'll focus on one or two, and then we'll do that for each of these classes of disorders. Again, we're only touching on them a little bit. There's a lot more information. I've included links on a lot of these for further readings or watching about them. So definitely make sure that you are checking those out. If that's of interest to you, that would be one of the best parts or one of the best things to look into. Alright, so we've got generalized anxiety disorder, panic disorder, specific phobias, and social anxiety disorders. And then there are other anxiety disorders in the DSM-5. Anxiety-related disorders like obsessive compulsive disorder, which we've used as an example a couple times today. So, the diagnosis and symptoms for generalized anxiety disorder are persistent anxiety for at least 6 months and an inability to specify reasons for that anxiety. So if there's no specific cause that still exists that is causing the continued anxiety, you might be diagnosed with generalized anxiety disorder. So etiology, another word for that, is the cause or the reason for the condition. So there might be biological factors here, so genetic predispositions. It seems like there might be GABA deficiencies, and so remember GABA is one of those neurotransmitters in your brain. Neurotransmitters do a whole lot of different things. So a GABA deficiency can do a whole bunch of different things. One thing that it might cause is increases in generalized anxiety. The brain responds more strongly, it seems, to everyday worries in people with generalized anxiety disorders. So that's an example of one of those things. Is that a cause or a consequence of generalized anxiety disorder? So are these biological factors leading to the generalized anxiety disorder? And because you have generalized anxiety, are you then more worried about general everyday things? Or are you more worried about general everyday things because of the anxiety disorder? Would you not be that worried if the other aspects of the disorder were taken away? So respiration is an interesting connection here. Essentially, the people with generalized anxiety disorder, on average here, so not every single patient, for example, seem to, when they're breathing, their respiration system is taking in air that is higher in carbon dioxide. So essentially it's not giving as much of the oxygen and nitrogen in the air, and the oxygen is that main piece that we really need. People with generalized anxiety disorder, when they're breathing, they're getting higher content of carbon dioxide. So, and that be having a little more carbon dioxide than an average person might lead to symptoms similar to feeling like you're under threat or having alarm frequently, when it's just the breathing and you're not getting enough oxygen. So the brain and the body are responding, saying, hey, something is going wrong here. I'm really anxious about not being able to get as much oxygen as I need to. So it might just be it doesn't seem that it's just that, but it's an interesting connection that seems to be correlated as well with people with generalized anxiety disorder, that they might not be getting they might be getting higher concentrations of CO2. So with that, there's also psychological and sociocultural factors. So having harsh self-standards for yourself, having critical parents, having negative thoughts, having trauma. So all of these things could also be seen as risk factors for generalized anxiety disorder. The more you add up, the more likely it would be to have a generalized anxiety disorder. So jumping on to another anxiety disorder is panic disorder. So this is a recurrent sudden onset of terror that occurs oftentimes without warning. So just sudden terror without anything to seemingly cause it. So heart palpitations are really common, extreme shortness of breath and chest pain because of that oftentimes, trembling, sweating, dizziness. Again, if you're not breathing or you're hyperventilating, you might be getting dizzy from that. Feelings of helplessness. Many people describe the feeling of a panic attack and panic disorder as feeling like they're having a heart attack or like they're going to die, and are really, obviously, if you feel like you're going to die, that's a pretty terrifying experience, right? So these are ways people who have panic disorder describe that. So with that, the brain is registering fear in the cortical limbic regions. So we've talked about some of these regions before. The amygdala, the hippocampus, the prefrontal cortex, they're all using the signals of alarm to kind of charge your body up for like that fight or flight, to give you that panic, right? So they are working still in these systems, maybe just not the way that they're supposed to be. So GABA, norepinephrine, serotonin, they might all be playing a role to lead to these symptoms in panic disorder. It seems there may be genetic predispositions for panic disorder as well, and conditioning to CO2. So again, we see some of that aspects of respiration, and if you're getting too much CO2, that might lead to learning to have panic disorders. Also, there are sociocultural factors and gender differences with panic disorder. So let's move on to specific phobias. And these are irrational, overwhelming, and persistent fears of particular objects or situations. So a phobia of spiders, a phobia of heights. So being a little afraid of a spider that might bite you might be a relevant fear, right? But having an overwhelming, persistent fear about a spider or a snake, which, sorry for putting them up on the screen, if that is one of your phobias, the example we saw a few weeks ago of the patient who was trying out the conditioning therapy, the exposure therapy, being exposed to a snake in the room with the therapist, their response was irrational and overwhelming, would be fall into that abnormal. They wanted the treatment because it was distressing to them. The response was very atypical, and it was personally, well, I said personally distressing. It was also harming their ability to do things in their day-to-day life. So fit those categories of abnormal. So for specific phobias, oftentimes it's psychological factors. We've learned even vicariously to be afraid of things, whether it's spiders or snakes or heights. So we might have learned from our own experience or from watching someone else. So if our parent was afraid of heights, maybe we would then also become afraid of heights because of seeing their reaction and learning that. It seems like we might have genetic predispositions for developing some phobias. We might have evolved the capacity to become scared of like snakes more easily than other things. We talked about that before. So I've got a bunch of different phobias listed here. So see if any of these are yours or if they are ones that you even thought would exist. So mysophobia, fear of dirt, is one that I was surprised about. Ailurophobia, fear of cats. If you've got that, sorry, I have had 2 cats in this video, and then they've been running around underneath my chair a couple times. Very distracting and loud when they're chasing each other. One of my fears, it wouldn't be like personally distressing and harming my day-to-day life, would be thalassophobia, basically fear of the open space of open water. So Yeah, let's just not talk about it. Pictures of the ocean, for example, of like whales swimming with divers. It's like so beautiful and awesome, but for me, it's also absolutely terrifying. I've even gone snorkeling a few times, and I like it. It's fun to like snorkel through reefs where I can see in the clear water. But if it gets like too deep, or like there's things way off in the distance, or it's too cloudy and murky of water, that is that fear of like what else is here in this water, or like swimming in a murky lake and there's like a branch touches your leg. Ugh. I, that it's not to like a phobia that I would need to get treatment for because it's not personally distressing generally. And it's not impacting my day-to-day work and whatnot. I don't have to deal with like going over open water to do lecturing, so I would not qualify as abnormal. My subscription to Reddit threads on thalassophobia, that is probably abnormal. No, I shouldn't make jokes like that. It's not actual abnormal behavior, but it is a little strange that I do that. I guess I'm just trying to desensitize myself to it. That's it. There is a purpose to it. I just thought of the purpose now, not because I'm trying to justify my own behavior. Um, yeah, thalassophobia. I'm not even sure if I'm pronouncing it right. It's kind of a strange word spelled. All right, so another anxiety disorder, social anxiety disorder. Intense fear of being humiliated or embarrassed in a social situation. So again, this would be impacting your day-to-day life, your ability to do things, your ability to have friends, make friends, go to work, those kinds of things, and be personally distressing to you. So a little bit of fear, or even a lot of fear of social situations, might not meet the definition of social anxiety disorder. Biological factors like genetic predisposition, neural circuitry, and serotonin seem to be involved here. So as we see, serotonin can be involved in a lot of things your brain does. You only have so many neurotransmitters, really, so each of them do a lot. Psychological factors like having overprotective parents as well as rejective parents is a big risk factor for social anxiety disorder. Social experiences, so having really poor social experiences, having a lot of negative feedback, kind of having situations where you're punished, not like people were intentionally punishing you in social situations, but you could, in an operant conditioning way, learn to be anxious about situations because of that conditioning, because of the punishment of a situation. All right, so obsessive compulsive disorder. So this is persistent anxiety provoking thoughts or urges to perform usually repetitive ritualistic behaviors to produce a certain situation. Usually the thing you're trying to produce is kind of a catharsis or stress relief. So you wash your hands a bunch of times to get rid of the worry of the germs that exist there. You make sure you don't step on a crack to get rid of that anxiety. And so it's persistent anxiety provoking thoughts. With that, it can be really distressing, make people lose time at work or things like that, and can be really tough to experience. I mean, all of these, I'm pointing that out here, but all of these can be really tough to experience. Saying that here does not negate that it can be really tough to experience any of these other disorders at all. So, might be genetic predispositions here. Overactive brain components in the prefrontal cortex and basal ganglia, maybe low serotonin, maybe low glutamate, maybe low dopamine. So again, those neurotransmitters, they do a lot of different things. Psychological factors like life stresses. So compulsions will often get worse as someone's stress level is rising. So if you have a final exam coming up, what'd you do, for example, in the class? It would tend to get worse. Those compulsions would tend to get worse. And then the difficulty filtering out negative thoughts as well. So there are some subtypes of obsessive compulsive disorder that you might have heard of. Hoarding disorder is a subcomponent, like the bigger umbrella is obsessive compulsive disorder. A subcomponent or a bubble under that umbrella is hoarding. Skin picking, hair pulling, and body dysmorphic disorder, which is often related to and can be a symptom and a cause of eating disorders like anorexia or bulimia. Body dysmorphic disorder is seeing your body in a very different way and then having compulsions and anxiety producing thoughts, doing some ritualistic behaviors to get rid of those anxieties. So lots of examples here. If you have an obsessive compulsive, if you have a compulsion to, let's say, if one foot steps on a crack, you have to step on the crack with another foot. It might lead you to, say, be essentially kind of skipping or hopping down the street so that you get your feet to hit the cracks in the right way, because if not, you have this anxiety ridden there. Talking about obsessive compulsive disorder reminded me of one of my compulsions, which is literally to double check locks multiple times. So I'm listening for my car alarm to activate there. So it's just funny. I've got that compulsion that probably, again here, wouldn't, while I might see that match in the symptom, that doesn't mean I have this disorder. Look at these things. So is it personally distressing to me that I double check the locks or just locked the car when I probably locked it before, when I brought groceries in? I actually remember doing that. So is it personally distressing to me? No. Is it impacting my life? Well, I mean, I did just do it on the camera, but it's also kind of an example for this. So is it impacting my life negatively? Doesn't seem to be. So all those things go into the definition of, is something abnormal or not. All right, so let's talk now about post-traumatic stress disorder, and I've got a lot more detail on this as well than some of the other disorders. So with this, oftentimes these kinds of symptoms develop as a result of exposure to some kind of traumatic event. So there's a lot of things that could lead to post-traumatic stress disorder. Some of those kinds of traumatic events are oppressive situations of any kind of sort, natural disasters, so earthquakes, unnatural disasters as well, being a victim of crime or witnessing crime or involved in crime. Combat is one of the most common, and one of the areas that there's most of the research done for, like veterans, for example, who have PTSD. Being in an accident, so whether you're in a car accident, that could do it. An accident where you were attacked by a dog or fell off a ladder or something like that. Those could all be traumas that could develop symptoms of post-traumatic stress disorder. So there's a lot of different symptoms. Again, just like the DSM-5, it's going to have this checklist. You wouldn't necessarily need to meet all of these, but these would be oftentimes something that people who have PTSD might experience. So anxiety, obviously if this is under the class of anxiety disorders, anxiety is going to be a common one. Avoidance of trauma reminders, so like avoiding anything that might remind you of things, locking away certain pictures, avoiding certain places, things like that. Flashbacks, quite common. Nightmares as well. Avoidance of emotional experiences, especially any related in any way to the emotions you might feel around the trauma. Emotional numbness, so that's one similar to a symptom of depression, like not feeling just kind of flat affect, not feeling happy or sad or angry, being more numb. Excessive arousal and startle responses, so being really easy to get more anxious and get to that fight or flight response. Difficulties with memory or concentration, not just about the traumatic event, but in general as well. So a person with PTSD might have problems memorizing a shopping list, for example, or remembering a person's phone number, remembering their own phone number, impulsive outbursts as well. So there are a lot of different treatments that can be very helpful for PTSD, and it is heavily researched right now. It's one of the more common ones to be researched in, say, the last decade. So I think there's a lot of good research on this. If you wanted to do a question paper, if you knew someone who needed treatment for PTSD, there's a lot of options. But it does seem that cognitive behavioral therapy is the best treatment overall. That is on average. For one individual person, cognitive behavioral therapy might not be the best, but just on average, based on research. it seems to be one of the most effective for the most people. So what it focuses on a lot of the times is changing the thoughts and beliefs and attitudes about an event. So if you think back to like theory of planned behavior and how attitudes are important, how our beliefs about things are important, how our thoughts and how cognitions work, working memory wise, and how memories are formed, if we focus on changing our thoughts about the traumatic events, we can even alter and change those memories to be reinterpreted in different ways so that they are less traumatic, so they're less likely to cause these symptoms that we just showed. So, cognitive processing therapy is one that does this. So this is under that umbrella of cognitive behavioral therapies. There's lots of different kinds. Cognitive processing therapy is one cognitive behavioral therapy method. So with this, you would focus on the impact of trauma. So this is CPT, cognitive processing therapy. You'd focus on the impact of the trauma. Like, what is it doing to you in your life? What do you experience about the trauma now? Focus on the negative thoughts related to the events. So like fear, anger, things like that. Replace those negative thoughts with new thoughts or reinterpreting of those events, and then cope with feelings as well. So those feelings of maybe anger or shame or disgust or pain or sadness. So another example is exposure therapy. So we saw this in the example of the snake a few weeks ago. So re-experiencing the event in a safe and controlled environment. So with a therapist or with a group, something like that. Something that helps you face it in a safe and controlled environment can let you be exposed to that trauma and sorry, I felt like I was about to sneeze, so I turned off the microphone and was waiting for that sneeze to come. But that's what exposure therapy is. You're being exposed to that trauma in a way to work it out or work through it. A newer therapy, EMDR, eye movement desensitization and reprocessing, is again another cognitive behavioral therapy. So is the big umbrella. This is one way to do it. I'm going to sneeze. It's going to happen. It's probably going to happen before I can turn the mic off. But EMDR is essentially a patient is guided through doing specific eye motions, so looking in specific directions or tapping their hands in specific patterns or specific ways. So you might be going slowly up or slowly down while recounting the trauma. So you're re-exposing yourself to it, and you're focusing on this other stimuli, moving your eyes or moving your hands, and focusing on that other stimulus, the hands or the eyes, focusing on doing that activity helps you to work on that trauma while recounting it. So you're essentially doing kind of these things together. You're doing a cognitive therapy, you're doing exposure, you're processing that trauma with this specific focus of what are your hands doing, what are your eyes doing, to get to a point where that trauma is not so disruptive. While you might get triggered by the trauma, but your symptoms are not as disruptive to your life. Mindfulness is also a treatment that's used with PTSD. It can be useful. You can see some of that here. You're focusing on some specific thing, your current experience. Here, you're also focusing on your current experience. So you can see some overlap between these. These are all under the umbrella of cognitive behavioral therapy. Biologically, there are medicines that have been tried. One of the most common treatments is an antidepressant, an SSRI, and a selective serotonin reuptake inhibitor. So it's blocking some of the reabsorption of serotonin in between the synapses. So this works in about 60% of patients who have tried it. SSRIs and therapy do seem to be the most effective way to treat. So a lot of other antidepressants have been tested as well, and other drugs also. But SSRIs have the most evidence, like the biggest body of evidence saying that they're the most effective. So there is even new drugs being tested now. So this is an article from 2016, so it's not going to have some of the newest drugs being tested. but you could use it as a starting point. Look through the links there for more information on the specific medical treatments that are used for PTSD, and then maybe go forward to do a question paper on this, or see what other medicines are being tested now for use in PTSD. So a lot of information there about PTSD. All right, so let's move on to dissociative disorders. So these are sudden losses of memory or even as much as change in identity. So dissociation is often you're dissociating with your current self, your current memories, your current identity. So my current identity and experience right now is I'm a professor, I'm sitting here on my computer, I'm doing my job, I'm working. If I had dissociated from that, it might be like, I forget doing this recording. That might be a small example of disassociation. To something big, maybe all of a sudden I forget that I am a professor and that this is my job, and I think I'm a snowboarder or something like that. There's not much snow right now. But that would be another example of dissociation with an identity entirely. So, oftentimes dissociations help people deal with extreme stress, and they're sometimes caused by emotional trauma and emotional memories. My cat is scratching my backpack. Hopefully it doesn't ruin it too much. So here are a couple types of dissociations that we'll talk about: dissociative amnesia and dissociative identity disorder. So dissociative amnesia is when an individual experiences memory loss regarding their own personal identity, and this is usually caused by extensive psychological stress. So this isn't just like me forgetting a couple minutes or that I did this recording. This would be forgetting my specific identity, even for just a short time. So, I think that example was hopefully clear enough. But that's different than dissociative identity disorder. Dissociative identity disorder is what had been called multiple plursons. There's so many plursons here. Oh boy. It used to be called multiple personality disorder, and I think that's an easy way to understand it. But essentially you're dissociating your identity. You're now another identity or multiple identities that you might dissociate between. So it's the same individual possessing two or more distinct identities or personalities. As we know, they're pretty connected, correlated. So each personality might have different memories, behaviors, and relationships. So if your wedding day, you were one of your personalities, your other personalities might not remember experiencing that event, as an example. That could be a really hard thing and a really distressing thing for a person, especially if their primary personality wasn't the one who was experiencing that wedding, right? Only one personality seems to be dominant at a time. So with this, it does seem to be a response, in many cases, not all cases, to severe abuse in early childhood. It also seems like the likelihood of having DID, dissociative identity disorder, does seem to run in families, so there might be a genetic component there. Also, some wonder if maybe there's a social contagion or social construction that is causing it. So essentially that maybe you're talking to a therapist about trauma and how you feel like a different person, and the way they talk about it kind of makes you actually go further in feeling like you are a completely different person, feeling like that's actually a separate identity. Are there cases of it being just that and not actually separate identities? Probably. There's probably a spectrum where people have learned it by social contagion, as well as having these completely separate identities. So, did I plan to watch this one? I don't remember if I checked this one before prepping the lecture today. Oh no, I wasn't planning to watch this one. That's why. So feel free to watch it. It does go over a lot more basic information about DID. And we already did watch a person with schizophrenia talking about that. But with that, the dissociative identity disorder, it's one that is ripe for storytelling, having one character being multiple characters, having different identities. There's a lot of different popular shows or movies that show it. People with dissociative identity disorder are not necessarily going to be violent or dangerous people. They're actually at higher, both people with DID and schizophrenia and borderline personality disorder, some that are traditionally seen as like some of the most dangerous or terrible or out there or something like that. They're actually at very high risk for crimes to themselves. We actually heard the example earlier today of a person with schizophrenia who had opened up the risk and for abuse. So that is the most common for these. All right, so let's move on from dissociative identity disorder to major depressive disorder and talking about depression. So diagnosis and symptoms here. Again, if you were in with a psychologist or psychiatrist, they would have the checklist for DSM-5, and they would be looking to see how much of this you matched, and then if you matched enough, they might diagnose you with major depressive disorder or depression or bipolar depression, something like that. So for major depressive disorder, some of these criteria are significant depressive episode that lasts for at least 2 weeks, daily functioning being impaired, so maladaptive there. The symptoms could include fatigue, a sense of worthlessness, reduced interest, even in things that generally are things that you might enjoy. So if you really like doing puzzles and you don't feel like doing puzzles anymore, that might be a symptom of depression as an example. Again, if you see any of these things common and you are worried about it, definitely see a therapist. You can get assessed, and even if not, a therapist can help in a lot of ways, even if you don't have a diagnosis of depression. So appetite and sleep disturbances are really common, as well as an inability to concentrate. So a lot of these are not symptoms that people generally think of when they think of depression. They think of depression, the word, sadness. So someone who's depressed is going to be sad. Well, not necessarily. So you might be sad. I mean, if you have a sense of worthlessness, you also might be sad, but you might just have no ability to concentrate. It's really hard to do things that might impact your work, your school, driving even. So it does seem like there might be some biological predispositions to depressions. We talked in our chapter on epigenetics. The word almost left me. We talked in our chapter on epigenetics about a couple genes that are connected and related to depression. So if you have a more stressful life, those proteins might now be doing something different and possibly lead to depression. Underactive prefrontal cortex, so this prefrontal cortex of your brain, regulation of neurotransmitters like serotonin, psychological factors. If you have learned helplessness, so we talked about learned helplessness in our classical and operant conditioning chapter. So we use the example of a dog in a Skinner box getting shocked on the entire floor. So it learns that it can't do anything to better its situation. If you have someone who is in a really poor situation where they realize they can't do anything to change it, they might learn helplessness, or they might not realize there's things that they can do to change it. They might end up with learned helplessness. That it puts you at really high risk for depression. Ruminating on negative or self-defeating thoughts. So keeping thinking of that thing that I said, or that bad thing I did, or that things are so bad. So ruminating, again, that kind of downward spiral. So sticking in that downward spiral rather than stopping or trying to go back to an upward spiral. It's a cause and consequence of depression, really. Pessimistic attribution is a factor that might lead to depression as well. Sociocultural factors like poverty, which is not too surprising if we look at poverty and learned helplessness. That connection's really clear. If you're in poverty, that can be incredibly difficult, and you might end up with learned helplessness or feelings of worthlessness. Poverty's not great. It'd be great if it didn't exist. And gender differences. Women are 2 times more likely to be diagnosed with depression. I didn't get the stats for what percentage of people do have depression, but it is not major depressive disorder, but depression is the most common mental illness. So, treatments for depression. This is some of the most relevant things, or some of the most up-to-date research is what I'm trying to say. Social support. So with that, social support needs to be the appropriate kind. So rumination is really bad. So we talked about that earlier as a symptom and a risk factor. So don't exclusively focus on negative things in life and symptoms when you're with others. So whether it's a family member, a friend, a group of friends, if all you're doing when you're with those friends are ruminating on the bad things, that's not going to be the kind of social support that will help treat depression. What it can help is depression. One of the symptoms, you might not be interested in doing anything. So a lot of people suffering from depression will isolate. So seeking out friendships and relationships can be a really huge support. Friends can help support you in your interests, remind you to do interests, encourage you to do things, so push you to do things that you love, even if it's something that you're not feeling like you want to do. You don't have that kind of motivation because of the depression. And this is tough because social support is so helpful for depression, but depression, you generally don't want to reach out. It's very hard to. So if you have a friend who seems to be suffering from depression, or you know is suffering from depression, and they're reaching out, maybe making an extra effort for them to reciprocate their reaching out, can be really helpful. Exercise is actually the 3rd best treatment overall for depression. So there's therapy, medication, exercise, the 3 best treatments for depression. With that, therapy plus exercise. So those are individual. So if you take medicine on their own, if you take therapy on its own, if you take exercise on its own, on their own, therapy and medicine are better just if you were to use only one. Therapy and medication, if you're therapy or medication, not and because it's or, therapy or medication would be slightly better than exercise if you're only using one. But if you're using more than one, which is good, therapy plus exercise is actually slightly better, has a slightly bigger effect size than therapy plus medicine. So therapy, exercise, and then if your doctors think it's a good idea and it would be appropriate for your symptoms of depression, then adding medicine in too would be great. So what kind of exercise are we talking about? Most of the research has been done on walking and jogging. So pretty low intensity workouts basically are the most researched, and it works. So anaerobic exercises work, and aerobic exercises, so things that get your heart rate up a lot versus things that don't get your heart rate up a lot. It's a lot of moving and using your body and using your energy and doing things is helpful for all ages studied. So I think the earliest study I saw was 11. Cat is trying to eat a Christmas tree now. Cats are nocturnal. They like to do things in the evening, which is when I tend to record these because that's when the kids are sleeping. Stop eating the tree, Shadow. It'll probably make you sick, honestly. So, again, anaerobic and aerobic exercises all are helpful. Sorry, I'm hissing at my cats. Off mic. So it is helpful for all the ages studied. 11 to 60s are the studies that I saw, but essentially whatever kind of exercise works for you. If you like swimming, awesome. If you like running, awesome. If you like biking, awesome. If you like doing lifting workouts, awesome. Yeah, so find what works for you, be moving, be doing exercise. It's one of the best things for treating depression. So the greater the length of the exercise program, so a program that's longer, or if you're doing it for 2 months or 4 months or 6 months, the 6 months one is going to end up having a bigger effect size on the depression, and the larger number of exercise sessions. So if you're exercising, let's say 4 times a week over the course of 6 months, 4 times a week would be pretty healthy to say do a HIIT workout or even a lifting workout focusing on like different muscle groups, or swimming 4 times a week. Will be better than swimming just once a week over the course of that 6 months. And then 6 months is going to be better than 2 months, as an example. So exercise is a really useful and helpful treatment that is sometimes overlooked. Medicines, there's been a lot of study. I mean, with it being the most common mental disorder, there's going to be a lot of research in it, and there's a lot of medicines that have been tried. So some medicines have worse side effects. And it's very individual which specific medicine might work for any individual. So generally, a doctor who's starting on medicine for depression will start with an SSRI. So that's a serotonin reuptake inhibitor. So selective serotonin reuptake inhibitor. So it's the most common, it's got the fewest side effects, and that's essentially why they start with it, because it has fewer side effects. SNRIs are working on serotonin and norepinephrine. Then we've got tricyclics and MAOIs, and they're just a little less common as we go down this list. If you want a lot more detail on these medicines, here's a good little article right there from Mayo Clinic. But there's been a lot studied that can work. Again, SSRIs are some of the most common. All right, so let's move on to bipolar disorder, which is a little bit different, but very similar in most people's experience to depression. So bipolar is characterized by extreme mood swings that include mania. But one thing to make clear is a lot of people with bipolar, most of their day-to-day lived experience with it will be experiencing depression. So the frequency and separation of episodes is usually separated by about 6 months to even a year. So most people with bipolar disorder, they go about 6 months to even a year without switching from that stage of depression into a stage of mania. So a person with bipolar is oftentimes, just in lay speaking, will say, oh, that person's super bipolar, which not a great thing to say for a lot of reasons, but it's also very inaccurate scientifically. So bipolar disorder, a person will probably be feeling depression for like 6, 7, 8, 9 months, 12 months, and then have a couple months where they're in a period of mania, where they're getting a lot of things done, they feel on top of the world, they feel like they can do anything, maybe even invincible, things like that. And then coming back to depression. So it usually is pretty long sequences of depression with shorter sequences of mania in between. So there is a strong genetic component to bipolar disorder. It does seem there are swings in metabolic activity in the cerebral cortex as well. And then the levels of neurotransmitters are highly correlated as well. I think we see the genetic component and the neurotransmitters, if they're not doing exactly the right thing, it can lead to a lot of consequences like these disorders we've been talking about. So I mentioned that it's usually a pretty long span. There is a thing called rapid cycling bipolar. So rapid cycling means it's really fast. It's faster than usual. It's unusually quick, but it's still classified as bipolar disorder. So that is 4 or more episodes of mania or depression in 1 year. So think about that. That's 12 months. Unless I made a mistake there. So 4 or more of those episodes within a year. So that would be like every 3 months. And that is about the quickest that we ever see people with bipolar have a change in symptoms like that. So that would be like a 3-month period of depression. Then maybe for rapid cycling, you might only see like a couple weeks to even a month or so of mania, and then back to depression for 3 or 4 months. So that's about the shortest periods you can see with bipolar. It's not a thing where they're changing day to day like that. Their depression symptoms might be worse or better day to day, but they will most likely be in a depressive state and then mania 4. Usually it's shorter. People usually don't stay in that mania for a long time, although any individual might. Usually it's repeated periods of depression and then infrequent shorter periods of the elevated or just normal mood. And so that's rapid cycling. I want to make that clear. It's one thing that just is talked about by lay people in that really derogatory way of, oh, that person's so bipolar. That's not an example of bipolar disorder. So, eating disorders. We'll breeze through these really quickly. They are more common in girls than boys. That's not why we're breezing through them quickly. We're breezing through them quickly because we can't spend as much time as each of these need to focus on them. We're touching on a lot and diving into a couple. So, anorexia is pursuing thinness through starvation. So you're restricting your calorie intake, restricting that energy, you're eating very little. Oftentimes there's an intense fear of gaining weight or of looking bigger in any way. There's a disturbance in how you experience your own shape or weight. So this person is looking in the mirror and they see themselves look very different than they are. So that's a distorted way that they're seeing their own shape. They're experiencing that in a different way. So anorexia typically starts in mid-adolescence, and it usually starts following a period of dieting. So you're dieting, you have increased stress. Those are a bad combination for then developing anorexia. So you maybe start a new diet, a normal diet, maybe you feel like you want to lose a couple pounds, then you've got your finals, and then your partner breaks up with you. All those things together would be high risk factors for then developing anorexia. So teens generally set pretty high standards for themselves, and oftentimes we can't meet those high standards that we set for ourselves. I say as if I'm a teenager, which I am not. And when they can't control those things, they might turn to something they can't control, like their weight, restricting their calorie intake, because they can control that. So family functioning problems are another thing that's a risk factor. So if family stresses are high and these other stresses are high, you've just started a diet, those are pretty high risk for starting it. Genes might play a role too, and that physical effect of the dieting itself, so that first kind of normal diet, might actually change your own neurology to make this distorted pattern the norm. So we've talked about habits, how memories are made, and how our neural systems have these networks together. So you might change your neural network, and that might be part of the cause, because you've now changed your neural network to make this distorted pattern of thinking and dieting the norm. And then as you do the behaviors of anorexia, it becomes more of a habit as well. Go away, cats. I wonder if you even heard I'll try to remember to listen back and see if I can hear, because that was a very loud hiss they just did at each other. They often like to play and fight in the evening because they are nocturnal. Alright, so bulimia. This is different. There's a binge and purge pattern through vomiting or laxatives. So with that, oftentimes people are eating a lot very quickly, and they have a lack of control of their eating during those episodes, and then they purge that food that they've taken in. And this needs to, like the criteria wise in the DSM-5, needs to be at least 2 times a week for 3 months. So there's a preoccupation with food and a fear of becoming overweight, often depressed or anxious, have a distorted body image as well. Oftentimes people with bulimia do fall within a normal weight range. Someone with anorexia will tend to be very, very skinny, so more skinny than average. A person with bulimia, they are taking in some calories, some energy, so in that way, neither of these are healthy eating disorders. But one, it's harder to catch bulimia, and two, you are taking in some nutrients, so they're both dangerous. But yeah, I'm just gonna say that they're both dangerous, but taking in some nutrients is a little better than taking in none. But that does make it harder to detect bulimia. The binge eating as well often sometimes begins during a period of dieting as well as stress. So cognitive behavioral therapy can help with either of these eating disorders, and it can be really really useful. Binge eating disorder is a little different. Recurrent episodes of out of control eating. No kind of purging or restricting intake later on, but just binge eating in pockets of time. All right, so let's move on to one of a lot of students' favorites to talk about, or one that students are interested to talk about, and schizophrenia. So, we watched the video at the very beginning of the person with schizophrenia symptoms. So think about that person as an example, or anyone that you might know that experiences schizophrenia as examples. See if you can match up these symptoms and some aspects of them. So it's the main piece of schizophrenia. We might think of it as the hallucinations is the main piece. Really, the main thing that makes schizophrenia, and one of the most anxiety causing symptoms is the highly disordered thought. So we talked about a disordered thought from the eating disorders, seeing your body in a distorted body image. Having highly disordered thought means that same kind of distorted thought pattern goes over many, many things, maybe even everything. So typically we see this and it's diagnosed in early adulthood. People with schizophrenia have a high risk for suicide. So positive symptoms, think back to our discussion of positive and negative reinforcement or punishment. A positive there is an addition to the situation. A negative is removing something from the situation. And it's similar here. A positive symptom is something kind of like added to a person's life. Negative is kind of taken away from a person's life. So positive symptoms is a hallucination or delusion. Hearing voices, seeing things, thinking of yourself as someone different, a delusion like that. So that is an example of a positive symptom that's added in onto that person. Disorders of movement as well are common. So tics, repeated patterns of movement that's kind of added onto the person. Disorganized speech can be a symptom as well. Negative symptoms are things like taken out of that person's situation, taken out of that person, you could think of it that way. So it's negative, it's removed. So social withdrawal, they're literally withdrawn from social situations. If you have highly disordered thought, you're really confused of like people's talking or what is real even, it can be really difficult to be socially active, right? Behavioral deficits, flat affect. So flat affect is like really neutral, not up, not down, just essentially really flat. Reduced speech, lack of initiative. So some of these sound similar to what you might have heard from depression, and it can look similar for those symptoms. So we've got those negative symptoms, we've got positive symptoms. The big key, though, to remember is this highly disordered thought. A lot of these are caused because of that highly disordered thought, leading to some of these. Cognitive symptoms like attention difficulties and memory problems are common as well, and the impaired ability to interpret information and make decisions. So think of the information coming to your working memory, your workbench, being highly disordered, being not exactly right, and not knowing which pieces are right, which pieces are accurate. Is this voice an actual human or something else? Like negative things. So having a flattened affect, not wanting to interact and do other things. Man, these cats are very noisy this evening. Sorry, it's distracting to me, and I'm probably distracting to you by commenting on it. Biological factors, probably genetic predisposition, structural brain abnormalities, and regulation, again, of neurotransmitters. Psychological factors, vulnerability stress hypothesis, essentially, do you have a genetic predisposition plus extra stresses? How many risk factors are you piling on? That makes it more likely that you will suffer from schizophrenia. And social-cultural factors also influence largely how the disorder progresses. So, if these negative symptoms are culturally not a problem, then your experiencing of the disorder won't necessarily be as bad. If the cultural ideas around the positive symptoms aren't so negative, your experience with schizophrenia might not be so bad. But if like the example of Eleanor that we saw at the beginning of this lecture. She mentioned her hallucinations, the hearing of voices, and her roommate was very nervous. Her guidance counselor was very nervous. That kind of experiencing that from the sociocultural environment, might lead you to see your symptoms as bad or scary or something to be worried about, right? And so we saw how that led her to a negative downward spiral versus when she had other supportive people around her, she was able to do more a positive upward spiral. All right, so I think this is a different person talking about schizophrenia, but we're not going to watch it during class right now. So let's talk about personality disorders. Before we do this, I want to remind you about personality just in general. So personality, the original thought behind personality, remember, was that a personality, and specifically traits, should be consistent across situations. So your personality disorders is something that's consistent across situations, or because these were described when that was the main idea behind personality. Now we know personality really isn't that consistent. Lots of things about social situations or different contexts can change it, but at the time these were named as disorders, personality was supposed to be that stable thing. So these disorders are something that we see is stable in multiple scenarios. These disorders are behaviors that we see consistent across different contexts and situations. So that's how it's connected to that personality. So antisocial personality disorder, you can imagine that being essentially antisocial across lots of different contexts, lots of different situations, school, work, home, in the community. If you're being antisocial in all of those scenarios, you might be diagnosed with antisocial personality disorder. So you might see things like law breaking, violence, a lot of lying and deceit without regret to these things, being really impulsive, irritable, reckless, and irresponsible. You might be diagnosed with antisocial personality disorder if those kind of behaviors are across a lot of different contexts. So with that, there might be biological factors, so genetics, the brain, automatic nervous system differences, so the ways the networks tend to create themselves might just be different for people with antisocial personality disorder. And that's really the only one that, of all these disorders we've talked about, this is really the only one that's at higher risk for doing crime, because doing crime is kind of part of its own definition. So if you're doing crime, that's an antisocial behavior. It's against society in some way. So that's what we mean by antisocial versus prosocial. At one level, it's prosocial is like pro-society, like for other people. Antisocial is like against other people. So this is really the only one that is actually connected with violence or law breaking, because it's actually part of its definition or the criteria to diagnose it. Borderline personality disorder is one that in some ways is very similar to what people think about when they say, oh, that person's super bipolar. Borderline personality disorder, personality itself is supposed to be consistent across situations. So borderline personality disorder is very impulsive and extreme across situations. Oftentimes, this leads to instability in personal relationships and self-image. So a lot of difficulty in forming good, close friendships, a lot of problems with anxiety and self-image for a person with borderline personality disorder. Oftentimes there's impulsivity, insecurity, unstable and extreme emotions. A lot of this seems to have some genetic factors, but also it's very common to see childhood abuse then lead to someone with borderline personality disorder. The irrational belief a person is powerless, unacceptable, or that others are hostile and having hypervigilance. So some of those sound counterintuitive and like they're opposite of each other. And in some ways they are. So a person who's impulsive and insecure and unstable and extreme in their emotions, they might view other people as maybe hostile, but also that they're powerless. That might put them on alert and be very anxious and ready to act or trying to run away. But also, they might have extreme emotions the other way. They might have feelings of compassion or love really massively. So if you had, say, a friend with borderline personality disorder, and you brought them a gift. You might see like a huge outpouring of love. You're the best person that they've ever known in their life. Their emotions are really extreme, but they're also unstable and maybe impulsive. So maybe you say the wrong thing. You say something that sets them off a few minutes later. They might flip back the other way and be very hypervigilant, think you're trying to attack them or hurt them in some way. So it's kind of an extreme example, but it shows that their personality is not consistent in any given situation. One minute you might be best friend, next minute you might be worst enemy, and that can make it really difficult to have relationships. They also tend to have this same problem with image of another person in their relationships with themselves as well. So that'd be very, very difficult to see yourself in a different light. It could be, I mean, this is maybe a little over exaggeration, but anytime you look in the mirror, seeing yourself as a very different person that way, liking yourself versus hating yourself a few minutes later, that can be really difficult on self-image and lead to a person being really distressed in their life and their lived experience. And that's one key point I want to get across with all of these disorders, is the lived experience of the people suffering from them. It's a disorder and it's considered abnormal because it has to be distressing to that person. It has to be maladaptive to them or other people around them in their life. So they're not fun or things that people generally want to be experiencing, right? So I do want to get that across for these. So let's talk about suicide. So jumping forward in the slides. So with that, there was over 40,000 completed suicides in the years between 2012 to 2014. It is the third leading cause of death in early adolescence. So it follows, I believe, accidents, so like accidental death, and I think car accidents as a separate category, but I don't remember for sure. But it is the third leading cause of death. For every completed suicide, there tend to be about 25 attempted suicides. So this doesn't necessarily mean that any one individual is going to attempt 25 times before completing a suicide. It just means on average that people make a lot more attempts than there are completed suicide. So with that, there are genetic components to suicide. Neurotransmitters, serotonin, dopamine, physical health is a big factor. Suicide's really prevalent in elderly population because of physical health diminishing, for example. Psychology, essentially having a desire to die plus the means to make that a reality is super high risk for suicide. And with that, culture, it varies by ethnicity and nationality. So different cultures have more prevalence of suicide versus less, versus more stigma for suicide versus less. And all these affect how likely or unlikely it is that a person will attempt suicide. So, sociocultural factors might not be too surprising. Chronic economic hardship leads to a higher risk factor of suicide. Being Native American, it is in many ways, over most of the U.S., synonymous with chronic economic hardships, especially for females who are Native American. So they're a very high risk group for suicide. These countries have some of the highest rates of suicides here. These countries have some of the lowest rates. Some of the reasoning and rationale behind that is that cultures that emphasize honor are more likely to have attempted and completed suicide. When there is no religious prohibition against suicide, it seems like it is more common. And then women are also more likely to attempt suicide. Men are more likely to complete a suicide. So this is the main thing I want to get across for this. If someone is threatening suicide or at risk for suicide, these are things to do. So these are kind of combinations of resources, like kind of distilled down to a couple bullet points. I've also got some links here. Your books has some resources. It's also kind of neat. One good thing Google does is if you ever have to search for like suicide. So for example, I do for looking up facts and new articles to share in class. The first thing will be like a suicide hotline. So it's easy to find resources for suicide. So when someone's threatening suicide, do take it seriously. Ask simple questions, do it calmly, and be a supportive listener. Listen to what they say. Emphasize, so this is a really big key, emphasize that those things that are unbearable, so chronic economic hardship, for example, is one of the big risk factors. Emphasize that even though that can be unbearable, and it might be for them, that it can be survived, that that person can survive that. So telling them something like, you can survive this, you can make it through, you can push through this, you can survive. That's going to be a lot more useful than saying something like, well, we'll talk about don't say these things in a second. So, and then I'll compare them. So stay with that person until help arrives, especially if they're threatening suicide. Stay with them if they have the desire to die and the means to do it. They should not be left alone. So encourage them to get professional help. Call professional help yourself. Encourage them to do it, though. That will be better. Getting them on board with getting help. So after the event as well, so maybe the threat of suicide is down. You go home, I don't know, take a bath, take a break. You might want to seek help yourself as well. That can be a really traumatic experience. Being there to support someone who's threatening suicide is something that, I mean, I wish no one had to experience, because I wish no one experienced the desire for suicide, and no one, in that case, no one would have to be there to help. But do help in these ways. Take it seriously. Ask calm, simple questions. Be a supportive listener. So listen more than almost anything. Emphasize that the unbearable can be survived. That's kind of like the most important thing to like deliver to the person, as well as getting help and getting them on board with getting help and staying there with the person. So don't ignore the warning signs. So don't refuse to talk about it. It's going to be hard. It's even hard to like think about and talk about in this kind of context. But don't ignore the topic. Don't try to brush it under the rug. If it seems like the person has that desire to die and means to die, it should be taken seriously. Do not react with horror or disapproval, because that can just make things worse, essentially. So be calm. Even try to put on your own therapist hat, essentially. So you might even be dissociating from the situation a little bit yourself. But don't react with that horror or disapproval or shame. Don't lecture judgmentally. Telling people they should be thankful because they have X, Y, and Z is really good in their life, because person B has these things that are worse, like you're not as bad off as them. Those aren't going to be very helpful things. So don't lecture judgmentally. Here I am lecturing and being judgmental about like a potential like statement you might say. So it feels a little ironic. Also, don't offer false assurance that everything's going to be all right. We talked about a lot of suicide comes from chronic problems, right? That things are hard. So offering assurances that everything's going to be okay, everything might not be okay. So they might still be in this dire economic situation for years and years and years, or their entire life, right? So don't give them the false assurance that everything's going to be all right. It's not as helpful as saying, hey, you can survive this. You have the strength to survive, to keep going, even though it's terrible. So maybe not say it the exact same way. I'm just trying to say it in different ways to give you different ideas, but I think that way might have actually not been the greatest way. So, but I mean, doing your best. And don't abandon the person once the crisis seems to be over. I mean, obviously you need self-care as well, but don't not call them for like weeks and weeks and weeks, right? Especially after they've threatened suicide. Is that? Yeah, that's it. All right, so we'll move on to combating stigma. So we've mentioned a lot of these things throughout the class, so there's not a lot more to go over, but we're kind of just taking all those components about stigma and combining them at the end here. So In studies of fake psychiatric patients, they felt stigma, other people felt stigma towards them if they knew they had some kind of diagnosis. And stigma is essentially a negative attitude towards the mentally ill. When similar to the stigma of racism, for example, there is, oh my goodness, I just forgot the term. Not reaction formation. It's not coming back. Essentially, even with the stigma of racism, you know that there's that stigma. You're more likely to act in ways to try and like show that that's not true, and that can put you at higher risk for things like anxiety and depression, which might be a downward spiral kind of situation here with these disorders. Also, the stigma of mental illness can put you at increased physical health risk, and this is combined with anxiety and depression as well, which is some of the reasons they're some of the most common disorders. So successfully functioning individuals with mental illness are really reluctant to come out and talk about it, so it's not something that people share generally. They don't talk about it. You can see generally someone with, say, a broken arm. They're in a cast, they have a sling, they're on crutches. Well, maybe not with a broken arm, they're on crutches. But you can see those kinds of injuries. Even with cancer, you can see someone who looks like they're going through chemotherapy treatment. For something like a chronic illness, where maybe someone has chronic pain, or a mental illness, you can't see things from the outside. And so it's, even though like there might be something literally physically wrong with a person where they're not producing enough serotonin, or they're reabsorbing it too quickly so that they are not motivated to do things, since you can't see it, it's harder for people to be more accepting. I think this has changed a little bit better in even the a little more than a decade that I've been in the field. So it's like a decade and a half, 15 years or so. Anyway, I do think it's improved even in that time, but there's still room to improve still. So this is a really interesting video of a woman who suffers from oh goodness, which was it, schizophrenia as well? But one of the main points here that she makes throughout it is stigma and the lack of support she had. Oh, clinical depression. Okay. I don't know why I thought it was the. I've got a bunch of different people's videos and their lived experience. So I'm not actually going to watch this right now, but it's a good one to watch to get an idea of some of the stigma that people experience. I think some of the examples that we've already watched today were good examples of that, so that's good. But since this is the end of this lecture, feel free to watch that. Most of the things that she says in the video are pretty factual and useful. There's one example that she gives, and a way that she talks about mental illness as a joke that kind of rubs me the wrong way, but like she's trying to do it as a joke, and I understand that, but it's a little bit misleading. That might make you want to watch it more and try to pick out where that is, but I think for the points that we've made throughout the class, I don't think watching this together as a class right now would do a whole lot. But if you want to see some more lived experience of a person and their symptoms, their experience there, the stigma, the lack of support that they had for it, as well as what they've done since, this is a really good example of that. So I would definitely encourage you to do that. So soon we will have the next chapter, chapter 13. We talked about a lot of treatments for disorders today, specifically around those disorders. So chapter 13 will be a little shorter since we've kind of covered some of it already. But we will focus on essentially the classes of kind of treatments that exist. So we'll do that for chapter 13. But thanks for being here today. I hope you learned a lot. Again, with that stigma, it is still a thing. It's something people feel, but with that stigma, getting treatment for any kind of disorder is a good thing. You might have to, like we see with some of the examples today, you might need to try a couple different therapists to find someone that you click with, that you can get a good therapeutic relationship with, so you know they're working for you, you are motivated to work as well, and you feel like you can both trust each other to pull you forward or push you forward. Yes, pull or push, you're moving forward. That's the main point. Another big key is, even though there's stigma for going and seeing therapists, they can help with a lot of problems. If you're just having struggles with anger management, you're having struggles with managing your time or your anxiety, even if you don't think it's to the level of a disorder, that's totally fine. They can help teach you skills, especially as psychologists can teach you skills and techniques to do better with things like memory or focus or attention in class or anything that you might think you need help with. So essentially, if there's all excuses for going to see a therapist are good excuses, essentially. So it's kind of the way it is. Any reason you might think to go to a therapist, it's probably a good enough reason. Go into it. And we can combat this stigma by changing the way we talk about things. We saw the two examples of people in those videos that created networks of people with their disorders, with on the autism spectrum, and with schizophrenia, specifically around hearing voices. So doing those kinds of things can help. Knowing what you know now that you might not have known a couple hours ago when you started this lecture about these disorders will hopefully make you understand it a little better, understand people's lived experience of them a little better, understand about them a little better, and hopefully reduce the stigma so that you, in your normal everyday conversations, will be helping to reduce that stigma too. So thank you very much for sitting here through this lecture. I know this one's a little bit longer because we're kind of combining some of Chapter 13 into here. That'll make Chapter 13 a little bit shorter for next time. So thank you.